Ma'am, we can start, ma'am. We're going live in 1 minute. Yeah.
Yeah, Sham, we can go online. Dr. Shadri is joining.
Yeah, ma'am. 1 minute, ma'am.
Are we online, Sham?
Yes, ma'am. We are online, ma'am. You can start, ma'am.
So good morning, everybody, and I welcome everyone to this World Thyroid Day webinar, which is based on today on women and thyroid. So we are going to discuss the topics which concern women as and when they are affected with thyroid, starting from the childhood to the puberty to the menopause. And I welcome all the speakers and the panelists and the chairpersons who have joined today's webinar and the audience, because we thought that we'll create more awareness about thyroid on this occasion of World Thyroid Day. And we know that World Thyroid Day we observe every time on 25th of May to create awareness about thyroid diseases, and that is the purpose of the Indian Thyroid Society. So under the Indian Thyroid Society banner, we are doing this program. Yesterday we had a program where we focused on pediatrics and thyroid, and today we are going to focus on women and thyroid. So with this, I hand it over to our president, Dr. Sheshadri. So he will be a little bit giving you the overview of today's program, and then we will proceed ahead with today's program.
Thank you. Can you hear?
So please go ahead, sir.
Thank you. Thank you, everyone. Sorry if I'm in a place where there is a lot of disturbance. I'm just being a Thyroid Day, part of several events, and I'm just in Trivandrum Airport. Yesterday, we had Dr. Narendra Prasad, President of the Endocrine Society of India, addressing all of us. The mission of the Endocrine Society of India and the Indian Thyroid Society are aligned, that we want to take the science, the clinical strenuousness, and translate it into meaningful action for our patients. Ultimately, the purpose for which both our societies exist is for the welfare of its members. But overarching all of that is the welfare of the patient community at large. This year, for the World Thyroid Day, Ravina, who has done so much of the work and deserves all the credit for the successful conduct of this program, when she approached me that shall we do something for World Thyroid Day, I said, let us focus on the people for whom it matters the most. And in this case, the women of the company. Providentially, the Endocrine Society, through Sri Nagesh, also approached me asking, can we focus on something in the pediatric area? And I said, absolutely. And the two of this can go well together. Therefore, you have this two-day program. The first day, yesterday, focused on thyroid disease in children. Today, we have a very, very well good line of issues affecting thyroid disease in women. So this is really a focus area of the Indian society, the focus area of the Indian thyroid society, and we are. I have also sort of commissioned several guidelines that will address this, and also these 2 days the seminar topics will become part of the thyroid research and practice publication. They will be peer reviewed, of course. But what we really want to do is to take what matters to our members, what matters to our community, and focus this. So the World Thyroid Day is a day of rededication of our society's commitment to the cause of patients who have problems with thyroid dysfunction. But also, I would like to call on to the ITS members at large that it is not enough that we give talks, that need to start focusing on research, that we need to start focusing on getting sure that thyroid work in India reaches every corner of the world. Also, one of the ways that you can contribute to the society, if you are not, if research and writing is not your cup of tea, is to review articles. Peer review is the most important way by which we ensure that the research that we publish reaches the right people and the wrong research doesn't reach the right people. Peer review is a very, very important process and a very, very important part of our contribution to our profession and our society. I renew this pledge asking every member of the IPS and every member of the ESI who is part of this, and also physicians to volunteer to peer review for our journal, which is a very, very important part of what we do. Again, I thank all my fellow office bearers, starting with Pramila and Sujoy, Arun, who runs everything behind the scenes, Mini, who makes us actually, financially able to do this, the past president, Dr. Shashank Joshi, and in particular, our patron, Dr. R.V. Jayakumar. I'd like to recognize him. I hope, Shyam, you can spotlight him for me. That Dr. R.V. Jayakumar is
Yes,
our
sir, yes, on it. Yes, sir.
senior most endocrinologist in the country. The man who brought thyroid into world prominence, a member of the Aorta Council, someone who deserves all our gratitude and appreciation for starting the society and putting it on the volume. Maybe he's off camera, but thank you, sir.
He's able to see, sir. Yeah.
That is there, sir.
And with that, I turn it back on to Pramila. Pramila, all yours. Let us make this matter for all the people who have dysfunctional thyroid, for the people who take care of patients with thyroid, and the professional societies of our two and the members of our two organizations who have gotten together to make more of this possible. Congratulations and thank you.
Thanks, Dr. Sheshadri. So now I hand it over to Dr. Ganvi to take the proceedings further, please.
Yes, ma'am. Thank you, ma'am. Thank you, sir and madam, for setting the tone. I welcome everyone and a good morning to one and all esteemed faculty and distinguished guests for our second day program on women and thyroid organized by the ITS in association with the ESI. So to start off the first academic session, that is on thyroid and puberty, we have our chairpersons, Dr. Rajesh Ratput, who is the director of the Department of Endocrinology at Medata, Gurugram, and Dr. Shaila Bhattacharya, madam, who is the consultant pediatric endocrinologist at Manipal Hospitals, Bangalore. So we are also joined by our expert speaker, Dr. Manilka Sumana Talike, who is a consultant endocrinologist from the National Hospital of Sri Lanka. So I request Dr. Shaila ma'am and Dr. Rajesh Ratput sir to introduce the speaker, Dr. Manilka sir.
Good morning, everybody. At
Good,
the
good.
outset, can you hear me?
Yeah, Shala, you are audible.
Yeah. Okay. Thanks, Rajesh. Um, I have a pleasure in welcoming Dr. Manilka, who is being consultant endocrinologist, National Hospital of Sri Lanka. He is currently the President Diabetes Association of Sri Lanka, former chairperson Sri Lanka Diabetes Federation. He has got a lot of feathers on his cap. So past Vice President Sri Lanka Medical Association, past President Sri Lanka College of Endocrinologists, former Secretary South Asian Federation of Endocrine Societies. So he is trained in endocrinology at the National Hospital of Sri Lanka and St. Bartholomew Hospital, London, UK. I also heard that he has been student in Manipal Hospital, that is Karnataka. So proud to have you here, Dr. Manilka. And he's also achieved a lot of other medals, and he's been in the national and regional guidelines in diabetes and endocrinology, has been a researcher, he's been an author, and also he has received a President's Award for Scientific Research in 2020. We welcome you, Dr. Manilka, to talk on thyroid and puberty. Over to you, Dr. Manilka.
Thank you very much, and thank you for the kind invitation, especially for the Indian Thyroid Society and to all the friends from India. I think I should put that my Indian connection also in my CV next time. Brings back memories. So let me share the. Is it visible?
Yes, sir. Yes, sir. Go on, sir. Yeah.
Okay, so it's an interesting topic that you all have given me and made me, read a lot and catch up on the latest physiology. So we will. I'm concentrating on women, but little bit of in puberty when you say in boys also I have mentioned here. It's not moving.
Sir, you can click on that and then start moving, sir.
Okay.
Yeah.
So the data, we don't have much of data in Sri Lanka, but the global prevalence, it's the commonest endocrine abnormality, thyroid, after, of course, the pandemic proportions of diabetes. And this recent paper, I think Uni Krishnan's paper says there are about 42 million Indians affected by thyroid disorders, and out of that, 90% of them are, hypothyroid. And the salt, iodization status is somewhat satisfactory, but it's still not enough. So these are some of the values I could get from your publications. This includes hypothyroidism, includes the subclinical and the overt hypothyroidism. The overt hypothyroidism is about anything between 2 to 3% in all the Indian studies that I notice, and hypothyroidism is even more less. So I thought before delving into the topic itself, I think it's all about physiology, where maybe some of us, most of us, which in college we didn't learn about all these new hormones. So it would be interesting to see how things have evolved and how new hormones have been discovered and how it is affecting puberty. And then later, let's see how the hypothalamus-pituitary thyroid axis also interacts with this system. All of us knew gonadotropin releasing hormones.
Huh?
Hello,
Sure.
can you hear me? Yeah.
Sir, go on, sir. Go on, sir. Yes, sir.
Okay. So we were taught in medical school, it's gonadotropin releasing hormone, the pulsatility, which will trigger the whole cascade of the gonadotrophs from the pituitary which will cause the sexual maturity and the whole process of gonads producing testosterone, estrogens, and progesterone with their usual feedback mechanisms. But this KNDY neurons and the kispeptin, neurokinin B, and dynorphin, which were discovered later and well explained and accepted, now is above GnRH, which stimulates or modulates the whole, pubertal process, where it gives the stimulation for the GnRH neurons to get activated. So it's a very interesting thing. It's good to know there are lots of interconnections when you, as you go on. And of course, fatty tissue is becoming one of the largest endocrine organs now, with more and more hormones being discovered, and leptin is one of them, very prominent. Lot of studies, and we know the functions of it. And another function of leptin is the neuropeptide Y in the hypothalamus, which was had an inhibitory effect on the gonadotrophin releasing neurons, is inhibited by leptin. In other words, in people with increased adiposity, adolescents, pubertal time with obesity, this may also partly explain the precocious puberty sometimes you see with obese children, both sexes, by inhibiting the neuropeptide Y. So that's the basic physiology, with some new hormones which have been added. And of course, above that level also, there are many factors which will affect the CNS, like your genetics, race, sex, and the bone age, the nutrition, your, sex steroids, cerebral lesions. So there are so many other factors which can influence the pubertal process from above the level of the CNS. So this summarizes, and I want to introduce, or you all may know already, but to recap this relatively newly diagnosed hormone called the gonadotrophin inhibitory hormone, which is affected, as you can see, by melatonin, then norepinephrine, and stress-related glucocorticoid. It all stimulates the levels in the hypothalamus of this inhibitory hormone, which in turn will inhibit kispeptin and gonadotrophin releasing neurons and decreases the neuroestrogens, which cascades down to delayed puberty or reducing the pubertal effects of puberty. And even through the gonadotrophin releasing hormone type 2 neurons, which secretes dopamine, oxytocin, and neuropeptide Y, many other hormones as given here, it alters the reproductive behavior as well, including libido and, desire to have a reproductive behavior also is changed by these hormones. Very interesting. And it acts at different levels. Hypothalamus, it may inhibit the gonadotrophins, plus at the gonad level also, it's inhibiting to a lesser amount the sex steroids as well. So this is an interesting thing. Mind you, these are all explained and done in mammals and animal studies. The reference is given here, molecular and cellular endocrinology. And with this background, let's look at puberty, growth, and thyroid function. Since the topic is that for today, thyroid hormones are, very essential for normal pubertal growth, as you all know. And the marked changes in the thyroid function also occur during this period of time in young girls and boys. And the physiological thyroid growth, what you call as the physiological goiter, what we see mainly is, they say it's involved with the factors involved with somatic development, that is growth hormone IGF-1 effect rather than any, TSH or TRH effect on the growth of the goiter. And of course, the growth spurt associated with puberty also may cause the physiological goiter. It's essential, and we know during puberty there is growth hormone secretion, which increases the TSH secretion in a paracrine manner and increases the metabolic rate and promotes tissue growth. So this is all part and parcel of the growth spurt. The thyroid hormones are also helping in the whole process, and the thyroid volume will increase as an adaptation to body and the sexual development that's happening. So I looked for any sort of normal ranges in India or in Sri Lanka or part of the world, but unfortunately I could not get hold of any data for that. But this study published in 2020 showed that the changes, subtle changes in the thyroid functions that are seen in children, adolescents, 12, 14, and 16 years, which is shown here, and the normal change. So it's basically, they say TSH may be normal or slightly on the high side, and free T4 in all age groups, it's pretty much stable. But the T3 changes, as you can see, age groups of 12 to 14, the curves have shifted, the density plots show a distribution more towards the right. That means, slightly higher levels are seen in this age. I think the Unikrishnan paper in your one, or there's a Kolkata paper with 1,000 school children in India. They have studied the 97th centile for TSH was falling between 6 to 8 milli-international units per liter. So these things we need larger studies and probably study our population more, especially our young women, to see what exactly is the normal levels for thyroid hormones in our part of the world at this age. So with that, again, the TRH axis and the TSH and the stimulation of the adipose tissue to produce leptin I have shown here, and the TSH also stimulates the adipose tissue. Thyroid hormones will inhibit leptin, as I told you before, acts as a permissive factor to initiate puberty. I have put the general symptoms of hypothyroidism and hyperthyroidism are pretty much the same, whether it's adolescent or an adult, but there are specific things like the slowed height progression and the delayed puberty that you can see with hypothyroidism, and the goiter, enlarged goiter, and the other symptoms are the same. Similarly, hyperthyroidism also, there is increased growth rate. It works either way. There could be delayed or even rarely precocious puberty, which we will delve into in the next few slides. And the other symptoms are pretty much the same. So what are the pubertal disorders related to thyroid dysfunction? Hypothyroidism, commonly the commonest cause of thyroid dysfunction, and it's more in female in India, Asia, and worldwide. And it's delayed puberty is the common association, but interestingly, there is precocious puberty also in very severe forms in a rare occasion. Hyperthyroidism, it's explained in some of the literature, both delayed plus precocious, but both are rare, but mainly it's precocious puberty in some of the papers that they are explaining. So let's get into hypothyroidism and puberty. Commonest abnormality, and it retards the growth and height development with secondary sexual characteristics, which results in delayed onset of puberty, but long-standing, very severe hypothyroidism, this incomplete isosexual precocity is also described with breast development and development of internal genitalia in girls. But ultimately, the whole pubertal process generally is delayed in the vast majority. So how are these two systems, hypothalamo-pituitary thyroid and the hypothalamo-pituitary gonadal axis, interact with each other? That's why I put all those things. Hopefully, this will be very simplified and you can understand better the physiology behind this. So one proposed mechanism of delayed puberty in hypothyroidism is through this gonadotrophin inhibitory hormone, which is a hypothalamic neuropeptide that will inhibit the gonadotrophin synthesis and the release. Basically, the GnRH pulses will be reduced or subdued. And in that chart, if you remember, it was clearly shown how this get inhibited, which I will show in another slide in a minute. Hypothyroidism also delays the pubertal delay and increases the hypothalamic expression, GnIH expression, and the gonadotrophin level. So that's clear. Then there is this TRH axis, where increased TRH due to increased, hypothyroidism will induce hyperprolactinemia, which in turn will inhibit the GnRH pulsatile secretion. So this is also postulated as another mechanism how delayed puberty can occur with hypothyroidism. Yeah, so this will explain how the thyroid hormones, when they are in normal level quantities, will inhibit the GnIH, gonadotrophin inhibitory hormone. So when in hypothyroidism, when it is low, that axis will be, inhibition will be gone and GnIH will become more active, and the cascade is, as explained before, shown, which will have this effect of delayed puberty. Here, this shows, I think it would be on Thyroid Day to recap our memory of what most, I wouldn't say all, but very important things when it comes to puberty and health. The effects of the thyroid hormones is shown here in this cartoon, which I'm not going to go through one by one, but you could see how prolactin is decreased by thyroid hormones, increases the growth hormone, increases TRH receptor expression, SHBG is increased, and many effects on the endometrium, uterus, and the endometrial shedding, all that, and the effect on the ovarian volume and the placenta, and the TRH axis, which will increase the prolactin, and the adipose tissue and leptin having inhibitory effect on the gonadotrophin releasing hormones. And it's a complex mechanism, and I think different levels of hormones will be giving different stimulatory and inhibitory signals to all these hormones, which we have to study. Coming to now that a delayed puberty with hypothyroidism, I hope you understood the postulated mechanisms and how it happens and the interaction between the two axes. All standard textbooks and papers will say under the causes of precocious puberty also there is prolonged and untreated hypothyroidism. So it's the two sides of the coin. How is it happening? So there are theories for this also, which arguable. We can, do more research on this and see. And occurring long-standing severe hypothyroidism, the specificity spillover theory, which is TSH, FSH, both have similar alpha subunits, and the T4 when it's low and the levels will go up, and high levels of TSH will stimulate the FSH receptor and stimulate estrogen production in girls and testicular volume in boys, which sort of a peripheral, peripheral precocious puberty is being caused. And then the theory of FSH-LH ratio being increased, and which is leading to the pubertal change. So few symptoms I have added boys here as well, just for the completion. Some of the things with incomplete isosexual precocity, that's what they call this condition when you get with hypothyroidism. These are some of the features that we see. So ladies and gentlemen, now we can see we have the two axes, but then interconnection of this with GnIH, leptin, and other factors are playing a role in this thing. And of course, we have this well-explained syndrome, Von-Wrigg-Grumbach syndrome, where this condition is explained by breast development, either congenital or childhood hypothyroidism untreated for a long period of time. Then they can get this syndrome with breast development, PV bleeding, short stature, and other features of hypothyroidism, but they don't get the typical gonadotrophin related central precocious precocity symptoms may not be there. Absent pubic hair, all that is very interesting. So these are some of the effects that we see with hypothyroidism and affecting puberty. What about precocious puberty in hyperthyroidism, which was documented? And this case report, I have given the reference here, you could read up. It gives a good idea about Graves' disease and the occurrence of precocious puberty in a young girl. And this could be also associated with McCune-Albright syndrome, where we know in endocrinology, the G protein activation, the post-receptor mechanism due to a genetic defect is activated, where you could get commonly acromegaly, Cushing's syndrome, and hypothyroidism is also part of the syndrome. It may be not causative, it may be correlate. Because of the syndrome, you can get hypothyroidism, and of course, precocious puberty also can be associated with this McCune-Albright syndrome. That is one. Most of the cases reported are actually syndromic, and there are few cases, even gonadotrophin dependent precocity. Earlier, the method I was telling was gonadotrophin independent in hypothyroidism, but here it's gonadotrophin dependent precocious puberty is also explained, which the trigger may be the advancing bone age or maybe the accelerated metabolism, which I told you, which the external factors which might trigger the brain hypothalamus and that system to get activated. So it's a very interesting area, not clearly explained in all the papers that I looked for, but I thought this case was a good one for you to read up if you are interested. So hypothyroidism and puberty, when you take it, you get some people, as explained, can get early puberty, but delayed puberty is also explained again in most of the literature with hypothyroidism. Because of you get accelerated growth and faster development of pubertal features are sometimes seen in most of the people. The initial acceleration could lead to a shorter final height, something like what they're explaining, something like what you see in congenital adrenal hyperplasias. And the menstrual irregularities are very common after puberty. They might go in for even secondary amenorrhea, and other aspects of sexual development also may progress slowly if the hypothyroidism is long-standing. So it's a very interesting but intriguing area. Of course, females and young children, adolescents, fertility is also a very important factor, especially in our part of the world. And I'm not going to go through subfertility; it is a topic by itself. But I thought it's because of the women and thyroid. There are so many effects on subfertility, puberty, and after that, subfertility associated with thyroid dysfunction, as the list shown here. But the PCOS is such a common thing, especially in Southeast Asia, which also has a connection with thyroid dysfunction. And so they say that it's about 5 to 10% prevalence in our part of the world. And hypothyroidism can initiate, maintain, or worsen by way of weight increase and other mechanisms. The PCOS is also affected. And of course, the data shows that thyroid disorders in women with young women with PCOS is 10 to 15%, much higher than the national prevalence data of 3 or 5%, or the maximum level with subclinical hypothyroidism. So there is a connection. PCOS, they postulate, may be because of the increased prolactin, which we're talking about, the TRH effect, and then the PCOS will result in the normal ovarian dysfunction and subfertility, and established hypothyroidism and subclinical hypothyroidism can cause the hyperprolactinemia, which may lead to subfertility or infertility rate. So treating hypothyroidism, they have shown that the fertility levels have improved. Males also, I just want a passing comment. There are changes that was observed in young boys after puberty, also associated with thyroid dysfunction, as shown here, and premature ejaculation being the main in the hypothyroidism, and erectile dysfunction mainly in hypothyroidism. So I thought, ladies and gentlemen, that's I have finished my presentation, and thank you very much for listening, and I'm happy to answer any questions. Thank you very much.
Thank you, Manalika. Just as you have mentioned, during puberty, there is increase in thyroid volume, and sometimes even goiter is discernible. So, for the benefit of general physicians, this is a common question. How do we differentiate whether we have to treat at this point of time, or we have to simply observe these children when they are progressing through puberty?
Sure. Oh, I think that's a very good question. We should do the thyroid functions in them and the thyroid antibody profiles. I noticed that in India, it's about 10% positivity in our part of the world after iodization program was started. If the antibodies are positive and the normal level of TSH is the issue, whether to treat or not. So if the TSH, I would say, is less than 7, and the child is not having any symptoms suggestive of hypothyroidism, or any unexplained biochemical changes like hyponatremia, unexplained hypercholesteremia, high CPK, or something of that supportive evidence is also not there, I wouldn't treat, just follow them up, height, velocity, and the other usual factors that you would do in monitoring a child or a young boy or a girl during puberty. I would say don't go by the goiter, because which is pretty much physiological and you could monitor. And by 16, 17, it will go down. We need country-specific or region-specific TSH cutoff values, which I feel would be very useful to decide when there is a borderline biochemistry, say like a TSH of 6.5 in a 12-year-old girl with a physiological goiter undergoing the pubertal process. So we need
Absolutely. Absolutely. We need a more normative data actually to sort out this issue, especially in those children who do not have any evidence of thyroid autoimmunity and their TSH is slightly high. Probably we need more normative data to sort out whether to treat such individuals or not. So I do not see any other questions from Analika. So if there are no more questions, we will like to thank you for delivering a nice and complex topic, which is puberty and thyroid. Try to simplify. I hope all of our listeners have benefited. Over to organizers.
Thank you, Rajput sir and Shaila madam for chairing the session, and Dr. Manilka sir for your valuable insights. So we now transit to the session on thyroid and pregnancy. So it's my honor and pleasure to welcome the chairperson and speaker for the next session. So chairing this session is Dr. R.V. Jaikumar sir. So as Krishna Sheshadri sir already mentioned, sir is the senior most endocrinologist of our country, and sir is presently the consultant endocrinologist at Aster MedCity, Cochin, and Dr. P.K. Jabbar sir, who is the professor and head in the Department of Endocrinology at Government Medical College, Trivandrum. And as the speaker for this session, I'm honored to welcome Dr. Jaideep Khare sir, who is the professor at People's Medical College, Bhopal. So I request Dr. Jaikumar sir and Dr. Jabbar sir to introduce Dr. Jaideep Khare sir.
Hello, thank you very much for inviting me to chair this session. And as you know, the topic is pregnancy and thyroid problem. And my person, Dr. Jabbar, who is with me, is not only is a professor and head, he is the principal of Trivandrum Medical College. So I offer my congratulations to him, and I invite him to take up the further portion of introducing the topic. The topic is pregnancy and thyroid disease is very important because, as you know, all the gynecologists come across this one, and they may refer the case to the endocrinologist, or they may continue to manage it. So a good information about the physiological changes that take place in pregnancy, when to diagnose and when not to diagnose is very important, and that will be all elaborated by the present discussion. I hand it over to Dr. Jabbar for introducing the speaker.
Thank you very much, sir. Say, founder, president, and my teacher, my mentor, and my examiner, great teacher, R.V. Jaikumar, sir, the distinguished faculties in the line, and speaker, Dr. Jaideep, friends. At the outset, let me thank ITS for arranging such a beautiful meeting today. Even though it's online, it's very, very useful. A lot of people are listening to us and speakers, and you have selected very elegant topics also. The topic already discussed by my teacher, Jaikumar sir, such a common problem. It's not a simple problem, sometimes little confusing also. But to sort out the problem, we have Dr. Jaideep with us. Jaideep is basically working as a professor of endocrinology at Bhopal, and is having and the good center also, JSS Hormone Center, and is having wealth of ideas and awards and honors to Dr. Jaideep. I don't want to take a lot of time because this will take a lot of time to introduce a person like Dr. Jaideep. Okay. May I invite with utmost respect Dr. Jaideep to start his presentation. Over to Jaideep, sir. Thank you.
Thank you, sir. Thank you for kind words, and thank you the ITS team for having me here on this World Thyroid Day. So as sir has already discussed that this is something, thyroid and pregnancy is one of the common condition which we very commonly see, and the gynecologists are always and the physicians are always worried about what has to be done. So I will be covering my topic under following subheadings that how to interpret thyroid function test in pregnancies, when to screen for thyroid dysfunction in pregnancies, and nutrition is something and lifestyle is something which is very important for any chronic diseases. So I will be just having a slide of iodine, which is important component for thyroid functioning. Then I will be coming over the various diseases commonly which we see in our pregnant humans, the hypothyroidism or euthyroid with T2 antibodies positivity, thyrotoxicosis, and thyroid nodule is just a slide of that. So, how to interpret thyroid function test in pregnancy? So, first of all, we know that pregnancy is a natural stress test for thyroid gland. As during pregnancy, there is increase in estrogen, so there is increase in thyroxine binding globulins. So, the free T4 and free T3 levels goes down. And the beta STG, which has the structural similarities with the TSH, stimulates the thyroid gland, and there it may be transient hyperthyroidism because of beta STGs, leading to increase in T3 and T4, and transiently TSH may get suppressed. Then there is increased metabolism of thyroid hormone in the peripheries, leading to reduction in the free T3 and free T4 levels. Plasma volume increases, and there is non-functioning fetal thyroid for 10 to 12 weeks, for which the maternal thyroid has to take care. For the demand of thyroid hormones increases by 30 to 50% during the pregnancy. So in normal pregnancy, what generally we see is the TSH is decreased. Free T4 levels are not changed, but the total T4 may increase. T3 may also increase. In hyperthyroidism, there is decrease in TSH levels, increase in free T4 levels, and the total T4 levels in T3 may or may not change. In hypo, the TSH generally increases from the reference ranges, and the free T4 and the total T4 may decrease, and T3 may not have any changes. And these are the various ranges which have been endorsed by our Indian thyroid societies, which we most commonly look after is the TSH levels. So generally in non-pregnant females, our target is to keep between 0.4 to 4.5. In first trimester, 0.1 to 2.5. Second trimester, 0.2 to 0.3, and in third, 0.3 to 3. But if there are no specific guidelines are there, then we may consider the up to the levels of 4 million international 4 milli units per liter may be considered as the upper reference range in the pregnant ladies. Because ideal is to develop, as in the previous talk discussion was going on, the idea is to develop more and more normative data for the local population. So when to screen? So what our society says that all patients, those who are planning for pregnancy, or those who are in early pregnancies, and or whenever they come to us, they should undergo screening test with the TSH levels. And if the TSH levels are within the reference range, then it's good and fine. If it is not, then we have to further work up. So here, as we have discussed, what are the reference ranges? Now, several times there are other complications like in central hypothyroidism, the TSH levels may be on the lower side, but the patient is having the signs and symptoms of hypothyroidism. So here comes that we should also monitor the thyroxine levels, T4 levels. So it can be total T4 or it can be free T4. But what, as we have discussed earlier, free T4 levels are usually recommended because it is not affected by the levels of the thyroxine binding globulin, and it helps in confirming the diagnosis of overt hypothyroidism, subclinical hypothyroidism, or even the hyperthyroidism. Because why it is important? Because in pregnancy we have seen that there is increase in the thyroxine binding globulin levels, so the total T4 levels may increase. So it is generally not recommended. And if we are using indirect analogy immunoassays, the total T4 levels may be on the higher side. But the drawback with free T4 is that it is a slightly difficult test, and ideally it should be done with the equilibrium dialysis and liquid chromatography, which is not available everywhere. So ATA 2017 guideline says that we can monitor with the total T4, but if we are monitoring with the total T4, we have to multiply the upper reference range of the total T4 by the 1.5 so that we can identify whether actually the patient is having hyper or just euthyroid. So these are the various guidelines which we have reference ranges which we have already covered, that in first trimester 0.1 to 2.5, second trimester 0.2 to 3, and third trimester 0.3 to 3.0. And if the ranges are not in these levels, then we have to confirm the diagnosis with the free T4 levels. Then iodine is a very important component. And during pregnancy, or the patient, those who are having goiter, or those who are hypothyroid, or even euthyroid, there is increase in iodine requirement by 50%. And which earlier in normal population, the requirement is approximately 150 microgram per day. But in pregnancy, there is requirement of approximately 250 microgram per day. And this increases because that EGFR increases, so renal iodine clearances go increases, and there is iodine transplantal transfer to the fetus, so iodine requirement is increased. If there will be iodine deficiency, patient lady may go into the maternal hypothyroidism with the goiter formation. So what hypothyroidism? As hypothyroidism is one of the most common endocrine disorders which we see in our practice. So if we have to talk about global hypothyroidism prevalence is 1.5 to 4% in pregnant ladies, but in India it ranges from 1 to 60%, which is quite high. And overt hypothyroidism 0.3 to just 0.5, subclinical from 1 to 3.5. And this was our data here, which was published as a meta-analysis 2021, that in Indian population, hypothyroidism is approximately 11.07%, subclinical hypothyroidism 9%, and overt hypothyroidism is approximately 2.7%. So how do we define that the patient is subclinical hypothyroid or overt hypothyroid? So if the TSH levels are more than 2.5 or 3 according to the trimester specific, with decreased free T4 levels is overt hypothyroidism. And in pregnancy, if the patient lady is having TSH more than 10, with whatever the free T4 levels are there, that may be considered as overt hypothyroidism and has to be managed accordingly. But if the patient is having the TSH between 2.5 to 4 of 2.5 to 10 with normal free to 4 concentration, then it is subclinical hypothyroidism. And why it is necessary to identify hypothyroidism? Because it has maternal, fetal, and neonatal complications. So this is the list which we have seen several times in several slides. Anemia, preeclampsia, placental abnormalities, low birth weight babies, infants, postpartum hemorrhages, myopathies, commonly seen in as maternal complications, cognitive impairment, neurological abnormalities, and the developmental abnormalities in fetus, and prolonged jaundice with hyperbilirubinemia, respiratory distress syndromes can be seen in neonates. So what guideline says that if the lady is already hypothyroid and taking some medications on for levothyroxine, and as soon as she is suspected or confirmed with the pregnancy, the whatever test is done or not done with the thyroid profile, we should increase the dose of levothyroxine by 20 to 30%, which can be done easily by adding 2 tablets extra on a weekly basis. What I used to do, I asked them to continue with the same doses, and on Saturday, Sunday, they may take 2 medications. But if the patient is not known case of hypothyroidism, and this patient comes out to be with the subclinical hypothyroidism, that is between the TSH is between 2.5 to 10, and then we have to decide. So the European Thyroid Association and the American Thyroid Associations have different criteria, which says that European Thyroid Association says that we may start with the dose of 1.2 microgram per kg per day in patients with the subclinical hypothyroidism. But the ATA says that whatever the weight is, 50, we may start with the 50 microgram, and then we may monitor how the thyroid function is going on over the period of 4 to 6 weeks. But if the patient is overt hypothyroidism, then we may start with the full doses, as our Indian guidelines also recommend that 1.6 to 2 microgram per kg per body weight we may start. But here NICE guidelines says that we may start with the higher doses, because hyperthyroidism is slightly well tolerated in pregnancy as compared to hypothyroidism. So now another thing which we commonly see is TPO antibodies. That on routine packages, they have got the antibodies done and it comes out to be positive. Now what has to be done? Whether the patient is, when the patient is euthyroid. So here I would like to say, when the patient lady is thyroid autoantibodies are positive, then TPO antibodies positive women are at higher risk of developing impaired thyroid response to the beta HCG stimulation during pregnancy. And if we have to talk about, the prevalence is approximately 18%. in general population, and every fifth woman may have euthyroid, but the TPO antibodies might be positive. So, TPO antibodies with hypothyroidism or euthyroidism may increase the risk of miscarriages, postpartum depression, gestational diabetes, placental aberrations, or other complications. So, what guideline says that if the lady is having TSH of more than 2.5 and the TPO antibodies are positive, then the patient may be started on the treatment. And but if the TSH is normal, then we have to look after that if the it is a precious pregnancy or the prior history of the complications in form of miscarriages or neonatal complications are present, then we may start with 25 microgram of levothyroxine, but it is a weak recommendation. Because there was a tablet trial which has shown that if the TPO antibodies are positive and we are on one arm we are starting levothyroxine and another arm we are not giving anything, there is not much difference in the outcomes. But for the placebo component, we may start. So this is the way which we uses for management of our hypothyroid patient. If the TSH is less than 0.1, I will be discussing about these things, thyrotoxic section next. Then if it is between 0.1 to 0.5, no further workup. But if it is more than 2.5 to 10, then TPO antibodies should be evaluated. If it is positive, then if it is between 2.5 to upper limit, we may consider the levothyroxine treatment, that is 2.5 to 4. But if it is between 4 to 2.10, then we should ideally start with the treatment. If it is TPO negative, then 2.5 to upper limit of that population, or if population range is not there, then up to 4 microgram, 4 million units per liter, then no treatment is required. But if it is between upper limit to 10, we may consider treatment with the low doses. So, but if the TSH is more than 10, the treatment should be given. So now another common thing which we see, but less commonly as compared to hyperthyroidism, thyrotoxicosis in pregnancy. So what is thyrotoxicosis? It is a syndrome in which there is hypermetabolism, hyperactivity because of the supraphysiological dose of the thyroid hormones. Most common is iatrogenic, that the patient is already on levothyroxine supplementation, but that is on the higher dose. So we have to just reduce those doses. Another common condition is of thyrotoxicosis, hyperthyroidism, which is most commonly seen because of the thyroid nodules or Graves' disease. So if I will be talking about the Graves' disease here. Graves' disease affects approximately 0.4 to 1% of the women in preconception period and approximately 0.2 in pregnancies. And gestational thyrotoxicosis is transient kind of thyrotoxicosis because of excess of beta HCGs, may be seen in multiple pregnancies or the molar pregnancies and it is most commonly seen in Asian population with the estimated prevalence of 1% to 11%. So what is first I will be talking about gestational thyrotoxicosis. It is, as I have told, that it is beta HCG mediated, and here excess of beta HCG cross react with the TSH levels, and there is elevated FreeT4 and suppressed TSH levels. It may be associated with the hyperemesis gravidum, which is most severe form, which is associated with the nausea, vomiting, and during the early pregnancies. And what we commonly see is the weight loss of more than or about 5% with associated with dehydration and ketonuria. Other causes of the beta HCG related hyperthyroidism are trophoblastic disease, partial or hydrated bone moles, choriocarcinomas. So and I will be talking how we will differentiate between Graves' disease and GTT also. And Graves' disease is another common thing, which is an autoimmune condition, because of the thyroid receptor antibodies, and these antibodies have several times crossed the placenta also and may affect the fetus also. So, what are the clues which favors that this is Graves' disease, not a gestational thyrotoxicosis? That in the preconception period also, patient might be having the symptoms of hyperthyroidism in form of weight loss, tachycardia, or palpitations, or there is family history of thyroid illnesses. The presence of big goiter is there, diffuse goiter is there, eye signs or dermopathy may be seen, muscular weakness is there, the heart rate is generally more than 120 per beats per minute, or in spite of good appetite, the lady is not able to gain weight. And clues which favors gestational thyrotoxicosis are that in preconception periods, there was no signs of hyperthyroidism, or there were similar symptoms in previous pregnancies also, because it is same response happens in or maximum pregnancies, the hyper responsive beta HCG level. And the investigation wise, with the FLET-T4 index, we can identify whether the patient is having gestational thyrotoxicosis or not. And the absence of TRAb antibodies suggests that it is most likely to be the gestational thyrotoxicosis. And in Graves' disease, T3 levels are slightly elevated more. So this is the same slide, how to be differentiate between Graves' disease and gestational thyrotoxicosis, and why it is important to identify thyrotoxicosis or overt hypothyroidism. Like in hypothyroidism, there are complications. So similarly, overt hypothyroidism has maternal and fetal complications, which may be improved after the treatment. So cardiac complications are common. The risk of thyroid storm is there, miscarriages, gestational hypertension, and fetal complications in form of prematurity, intrauterine death, low birth weight infants may be seen. So how do we manage it? So if it is a gestational thyrotoxicosis, we basically need supportive treatment with the proper hydration, and anti-thyroid drugs are usually not required. We may give beta blockers in initial time, but these also should be avoided in later pregnancies because there is risk of IUGR and placental insufficiencies can be seen. So, but if it is Graves' disease, the other cause of hyperthyroidism is there, then anti-thyroid drugs may be used. And in first trimester, generally PTU is preferred over methimazole or carbamazole, but now we can use anything. And what are the initial recommended doses is of the PTU is 100 to 150 milligram per day in 3 to 4 divided doses, or methimazole around 10 to 20 milligram per day, but several times we may require higher doses. So, and the clinical improvement can be seen after the starting of the anti-thyroid drugs over the period of 2 to 6 weeks, and the thyroid functions improves over the period of 4 to 8 weeks. So, as we know, we generally want that these molecules may be avoided because these molecules have similar placental transfer kinetic transfer is present. So there are some side effects, teratogenic effects with the methimazole, especially which we are worried about: aplasia cutis, corneal atresia, athelia, and developmental delays, omphalocele may be seen. And with the PTU, more common are the urinary tract dysfunctions or malformations of the faces and neck regions may be seen. So, and in Graves' disease, generally, over the period of time, if the patient is diagnosed with the Graves' disease several times, after 20 weeks of gestation, the requirement of anti-thyroid drug goes down and patient doesn't require, because after 20 weeks, there is suppression in the autoimmunity because of the hormonal changes. So another topic is thyroid nodule and pregnancy, which I will not be covering because we have full session panel discussion in the last. So thank you for patience hearing. If any suggestions and any questions, we can discuss here.
Thank you, Dr. Jaydeep, for the excellent presentation, covering just a vast topic in the very shortest time and giving all the highlights. I got only one or two comments. One thing is the carry home message for our delegates is one is that screening, because American Thyroid Association put 10 or 11 classes if they are having those classes to screen, but it's not possible. I think better universal screening in Indian surroundings is better. That is what I personally feel. And I think the Indian Thyroid Society last panel discussion also we agreed universal screening is justified. Second one point you didn't mention is, see, nowadays people are working abroad, they come here with pregnancy and their abnormal thyroid function test, and somebody told them the question is there a place for MTP, termination of pregnancy because of the thyroid disease? Because I have seen people referring gynecologists, the TSH is 100, so please arrange this one, permission for MTP or TSH thyrotoxicosis. That is all not there. If the patient there is no justification for ordering an MTP on the basis of a thyroid disease of pregnancy, you start immediately treatment. And the third question, the message we must cover is all the physicians and the gynecologists must be aware that the normal physiological changes of TSH must be aware. So don't put the patient, the moment they see a low TSH in the first place, oh, they have got thyroid disease, go to the endocrinologist or get the MTP done. I think that is a wrong thing. So that message must be carried home. And there is no place for MTP, and universal screening is the best thing. And during pregnancy, thyrotoxicosis, I always advise to don't try to achieve biochemical thyroidism. Just clinical improvement is enough, because the doses are going to the baby. So
Yes,
these are my few comments. Any other comments from the audience? Dr. Jabbar?
No, nothing, sir. The carrier message is very clearly conveyed. And I have a feeling that I'm working in a very busy hospital. And as sir said, a lot of people are starting PTU unnecessarily.
Right.
Don't think that a PTU is a very benign molecule. Sometimes that will burn your finger, right? And PTU, as per the current recommendation, you give only in the first trimester. But see, is it really needed? I think first, for taking a decision, crucial decision, those who are listening to us, get a consultation from endocrinologist before starting any drug. Hypothyroidism, as sir said, is not a big deal, but thyrotoxicosis sometimes, that will be a biggest headache for physician and patients. And monitoring also should be very much highlighted, because simply starting anti-thyroid drug and looking for FT4, and people are looking for TSH, and modifying the drug is also, please don't do that. Just maintain, as Professor Jayamar sir was discussing, you just reduce the symptomatology and monitor the patient. And fetal monitoring also very, very essential. See, various regimens are available. All these points, please consider and talk to your colleague in endocrinology and take an appropriate decision. These are the take-home message from my side. Thank you very much.
Thank you, sir. Thank you, sir.
Thank
You are
you.
muted,
Sir, you
sir.
can unmute, sir.
You're muted, sir.
Sir.
RV sir, you are muted.
Yes, sir. Unmute, sir.
RV sir, you are muted.
Okay. Any comments in the any questions in the chat box?
No, sir. No, sir. Everybody said thank you, sir. Yeah.
Okay, I think I must thank Dr. Jaydeep for the excellent presentation, covering the topic, such a vast topic in a shorter time, and giving the very sharp points for us to take home. And
Thank you, sir.
Dr. Jabbar also commenting about the thing and introducing the speaker. And I thank the organizers for giving me and Jabbar a chance to chair this session with Dr. Jaydeep.
Thank you, sir. Thank you, sir.
Thank you, Dr. Ravi Jaikumar sir, Dr. Jabbar sir, and Dr. Jaideep sir for your valuable thoughts. So up next is our session on thyroid and osteoporosis. And to chair this session, we have Dr. Bipin Sethi sir, who is the Senior Consultant at Care Hospitals, Hyderabad, and Dr. Ashraf Jani sir, who is the Professor at SKIMS, Srinagar. A warm welcome to our distinguished chairpersons. So speaking on the topic is Dr. Amritava Ghosh, Associate Professor at AIIMS, Raipur. I request Dr. Bipin Sethi sir to introduce our speaker.
Thank you. It's a privilege to be part of this session, and Dr. Ghani and myself will be looking after this session. This topic is very interesting. The nature's experiments wherein you have thyroid hormone resistance and other aspects have tried to point out whether it's the TSH or the thyroid hormones which are responsible for osteoporosis. The good thing about these disorders is that they are usually recognized well, especially the overt ones, and the likelihood of they causing permanent issues with the bone is very limited. The primary hypothyroidism, secondary hypothyroidism, thyrotoxicosis, or hyperthyroidism. And the only time that we are concerned about this is when we are giving producing iatrogenic thyrotoxicosis for thyroid cancer patients, especially the ones which are not having complete biochemical remissions, but they give us an insight about what is the interaction between thyroid hormone, thyrotropic hormones, and the bone. I would request Dr. Ghani to introduce our speaker, and then he can take it forward. sorry, since I don't see him, I'll introduce. He is an associate professor and faculty in charge, Department of Endocrinology and Metabolism at AIIMS, Raipur. He has 20 years of total clinical and academic experience with 25 research publications. He has been presenting papers prolifically. He has chapters and as authors and editors in 6 books. He has 25 research projects as PI, co-PI, and is a reviewer of many journals. Without much ado, I request you to make your presentation, Dr. Ghosh.
Thank you, sir. Thank you very much for the kind introduction. First of all, I would like to thank the ITS and the organizing committee for inviting me to this occasion. I'd share my screen. Is it visible?
Yeah, it is now visible.
Okay, sir. Okay, so my topic is thyroid and osteoporosis. So I just start with a brief introduction, followed by the skeletal effects of thyroid hormones in euthyroid individuals, and then the skeletal consequences in various thyroid disorders. And finally, I just touch upon the management of bone health in patients with thyroid disorders. So we are all aware of the hypothalamic pituitary thyroid axis, where TRH regulates the TSH and which in turn stimulates the production and release of T3 and T4 thyroid hormones, which in turn exert a feedback at the pituitary and hypothalamus. So how is it related to the bone? Well, bone has thyroid hormone receptors, beta 1 and alpha 1 receptors. Predominantly, it is the alpha 1 receptors. So, the T3 acts directly on the alpha 1 receptors. So, alpha 1 receptors are 10 times more prevalent compared to the beta 1 receptors. And in addition, it has been proposed that TSH also has direct actions on the bone cells, both osteoblast as well as osteoclasts. So where does bone fit in? Well, we are all aware of the bone turnover cycle, where initially osteoclasts will start a process of bone resorption, which is a shorter process, lasts about 3 to 5 weeks, followed by apoptosis of the osteoclast, after which the osteoblast precursors and osteoblasts move in and start bone synthesis, first by release formation of osteoid, which subsequently undergoes mineralization. So T3 may regulate the osteoclast proliferation, differentiation, and function, although this is contested. T3, more established is the role of T3 of regulation of osteoblast, which it promotes the proliferation and differentiation of the osteoblasts, which in turn further again stimulates the osteoclasts. So in euthyroid individuals, thyroid hormones play a role in the maintenance of normal bone health and the bone turnover cycle. TSH and bone turnover markers correlation have been studied in various studies. However, the results are conflicting. While some studies show that TSH is helpful in reducing the bone resorption markers, these other studies have shown that there have been no association between TSH and bone turnover markers. There have been several studies which have evaluated the association between FT4 levels or TSH levels with bone mineral density or the fracture or fracture risk. So in fact, there have been a couple of meta-analysis also. So in one meta-analysis, which studied more than 56,000 patients, lower TSH and higher FT4 levels were associated with an increased risk of hip fracture. In another study, again a meta-analysis done on post-menopausal women, which included around 24,000 subjects. Here, TSH was again positively related with bone mineral density. So to summarize, the higher T4 and or lower TSH within reference range are associated with decreased bone mineral density and increased risk of fracture. So the effect of thyrotoxicosis on bone, hyperthyroidism causes high bone turnover state with increased frequency of initiation of bone remodeling sites together with increased bone resorption and formation rates. So the normal remodeling cycle lasts around 200 days. However, in thyrotoxicosis, this gets shortened to around 100 days. So the cycle duration is shortened. So both the bone resorption phase is shortened as well as the bone formation phase is shortened. However, the bone formation phase is more significantly shortened compared to the bone resorption phase. So with each remodeling cycle, there is around 10% loss of bone. So thus hyperthyroidism is associated with high bone turnover, accelerated bone loss, and leads to osteoporosis and increased fracture susceptibility. So various clinical studies have evaluated the effect of thyrotoxicosis on bone density, and most studies have found consistent results of decreased bone mineral density associated with overt thyrotoxicosis. Hyperthyroidism has been found to differentially influence the trabecular and cortical bone metabolism, with the latter more predominantly affected. The distal forearm BMD measurements are therefore appropriate for studying thyroid effects on bone. Also, lower BMD is noted in lumbar spine, total hip, and femoral neck. So, how it affects the fracture risks? There is a 30% higher fracture risk of forearm, hip, and vertebral fractures with TSH values less than 0.1 compared to TSH values higher than 1. So it is an established risk factor for fracture developing later in life. So, of course, when a patient comes to us with hyperthyroidism, we treat the patient. So whether treating the patient leads to improvement in bone mineral density, improvement in risk of fracture. Well, the initiation of antithyroid therapy and successful achievement of euthyroid state can reverse the extent of osteoporosis induced by overt hyperthyroidism. The bone turnover markers decline promptly and are usually normalized in the first 2 months. The BMD gradually improves over the subsequent months. Although it may be incomplete. So, recovery of bone density with effective antithyroid drug therapy within first years of initial therapy continues to occur. However, even after 5 years of therapy, there may be some residual impairment of bone mineral density. So, one of the studies, BMD remained 5 to 16% lower than controls at 18 to 24 months of follow-up. So actually in us, one of my DM trainees is working on this, and this data has been extracted from his study. So among 54 patients with Graves' disease who have been on treatment for more than 2 years, having a mean age of around 45 years and predominantly female population, the patients we included patients who were not in remission and were on continuous antithyroid drug therapy, and in them the bone mineral density after more than 2 years of therapy, the Z score, particularly at the radius, continued to be on the lower side. Subclinical hyperthyroidism. Of course, there have been several studies which have evaluated the effect of subclinical hyperthyroidism on bone mineral density. So there have been few meta-analyses which have also been published. So most of these meta-analyses have shown consistently that subclinical hyperthyroidism is associated with a lower BMD, while 3 of these meta-analyses which have focused on risk of fracture have again confirmed that there is an increased risk of fracture in patients with subclinical hyperthyroidism. So, to summarize, subclinical hyperthyroidism was associated with bone loss and fracture, particularly in individuals with endogenous disease, particularly in patients who are elderly, postmenopausal women. TSH values less than 0.01 was associated with 2 to 3.5-fold increased risk of hip and spine fractures, respectively. Hypothyroidism is a low bone turnover state. There is a net increase in mineralization without major change in volume. So, over many years, theoretically, it is expected to have a slight increase in bone mineral density. Although such prospective clinical studies actually need to be done over many years, and there are few such studies. Most of the data have emanated from either retrospective studies or cross-sectional studies, and which have mostly shown normal BMD. Similarly, subclinical hypothyroidism also, clinical studies have shown normal BMD. So, of course, these patients are treated and how it affects the bone mineral density. So, most patients after starting treatment of thyroxine show a slight decrease in BMD, although normal bone mineral density is maintained in most of the patients whose TSH is maintained within the desired euthyroid range. However, it should be remembered that often we tend to overtreat. So, prevalence of exogenous subclinical hyperthyroidism is very common. In fact, it is more common than endogenous forms. And particularly, it is due to widespread use of thyroid hormone supplementation. Sometimes, when
I'm just going online 5-10 minutes, but I can talk.
Pardon?
Sir, go on, sir. Go on, sir. Please continue, sir.
So, and it is of particular concern in the elderly. So, meta-analysis in elderly population and particularly in postmenopausal women have shown significant reduction in BMD. And in one of the meta-analysis on postmenopausal women, BMD decreased by 9% after 10 years of thyroxine replacement compared to controls. While the loss was significantly lower in premenopausal women, amounting to around 2.7% loss in BMD. So of course, initiation of antithyroid drug therapy in patients with hyperthyroid. So I'm just discussing the medical treatment options for secondary osteoporosis, particularly in patients with hyperthyroidism. So the initiation of antithyroid drug therapy in these patients and successful achievement of euthyroid state can reverse the extent of osteoporosis induced by overt hyperthyroidism. Some studies have explored the combination of bisphosphonates and antithyroid drug. So in one of the studies, a combination of methimazole and alendronate showed significantly greater improvement in lumbar spine and femoral neck compared to methimazole alone. So in lumbar spine, the BMD increased by 6.2% compared to methimazole alone, where it increased by 2%. Similarly, in femoral neck, it increased by 2.1% compared to methimazole alone, where it increased by 1.4%. Relationship between vitamin D levels and BMD in patients with newly diagnosed hyperthyroidism have been evaluated. The bone mineral density and Z scores have been found to be significantly lowered in those with vitamin D deficiency at the time of diagnosis compared to those who are vitamin D sufficient. So if vitamin D deficiency is detected, it should of course be supplemented. So this flowchart summarizes the approach to women with hyperthyroidism. So in premenopausal women, DEXA should be considered, and it is of course recommended if the woman is postmenopausal. In premenopausal women, if the BMD is low, calcium and vitamin D supplementation should be given, and additional osteoporosis therapy should be considered. If normal BMD is there, then calcium and vitamin D supplementation may be considered. In postmenopausal women, if the woman is osteoporotic, we need to treat osteoporosis. If there is osteopenia, again, osteoporosis treatment should be considered. In normal BMD, only calcium vitamin D will suffice. And the similar flowchart should be followed for patients aged less than 70 years and those aged more than 70 years. Particularly if the age group is between 50 to 70 years and they have high risk of fractures, we should again consider them as we are considering those aged more than 70 years. Those with osteoporosis should be treated. Osteopenia, again, osteoporosis treatment considered, and in other patients, only calcium vitamin D is sufficient. Many patients of differentiated thyroid carcinoma require suppressive TSH therapy. These patients are at an increased risk of bone loss, and of course, these patients can have decreased BMD and increased risk of fracture. So these patients should also be considered for therapy. If the patient is premenopausal or the age is less than 50 years, DEXA should be still considered, and those with low BMD, treatment should be considered. In postmenopausal women or in men more than 50 to 70 years, DEXA should be done, and those in osteoporosis should be treated. Those in osteopenic range should be considered for treatment, and those with normal BMD should receive calcium vitamin D supplementation. The patient should again and again be evaluated whether the TSH suppression range is adequate. If the patient is showing any excellent response, particularly in patients having excellent response, TSH suppression should be avoided. The ideal TSH range in these patients should be 0.5 to 2. So this again, I've already covered this, and this is the men with TSH suppressive therapy, similar to pre and postmenopausal women. So I'll just summarize. Receptors for thyroid hormones and TSH are present in bone. These hormones may act directly on osteoblasts and osteoclasts. Thyroid hormones play an important physiological role in maintaining adult bone strength and structure. Thyroid hormone status is related to skeletal outcomes. Thyroid status at upper end of euthyroid reference range is associated with low BMD and increased risk of fragility fracture. In hyperthyroidism, bone turnover is accelerated twofold with a net loss of bone. The severity of hyperthyroidism correlates with decreased BMD and increased risk of fracture. Similarly, the duration of hyperthyroidism also correlates with the low BMD. Hyperthyroidism affects the cortical bone to a greater extent compared to trabecular bone. Women over 65 years old with TSH less than 0.1 have greatest fracture risk. Normalizing thyroid function alone is able to affect some reversal of bone loss. Although anti-thyroid therapy combined with vitamin D and bisphosphonates is more effective in normalizing bone mineral density. Subclinical hyperthyroidism is associated with bone loss. Hyperthyroidism induced by thyroid stimulating hormone suppressive therapy in patients with differentiated thyroid carcinoma is a cause of secondary osteoporosis. There is lack of evidence on the negative impact of hypothyroidism on bone health. Thank you.
Thank you for your nice section and presentation. Dr. Gani, your comments?
Hi, very nice presentation by Dr. Amrita Ghosh. I think this is the conventional understanding, and a lot of data is there that when your TSH gets suppressed below some centiles, your bone density centile also falls. Fracture risk is increased. But how I would like to take your attention towards some recent data some controversies have crept in from Korean National Health Study data, where they had some 1 lakh patients assessed with thyroid cancer, 25,000 around cases and 75,000 controls. And along with few more studies, there is some meta-analysis saying that there is a J-shaped curve in fracture risk. What they want to say that in thyroid cancer patients, paradoxically, the requirement of anti-resorptive therapy as well as fracture risk was lower than the controls. So I do not know what are the issues, bone markers, they have not assessed this actually insurance database. But we need to also keep that newer data coming up in mind to actually interpret. So I hope you have reviewed other similar papers while preparing for the talk. That is there any such reason? Because people have also linked TSH directly to the bone density. So they say that TSH is something directly to do with the bone, bone remodeling unit.
Yes, sir. Point well taken, sir. Yes, TSH, particularly TSH receptors have been found in both osteoblasts as well as osteoclasts. And it has been postulated that TSH directly acts on these cells rather than in the effect of their T4. So initially it was postulated that in hyperthyroidism, it is the decrease in TSH that is causing osteoporosis rather than the increase in T4. However, in subsequent studies, this was refuted. So, of course, this is an important point of discussion.
Thank you. There are no questions. I think the message that we get that there are issues with bone with thyroid. We should not be over-generously treating patients with subclinically hypothyroidism or hypothyroidism to suppress their TSH below normal. And also patients with thyroid cancer differentiated should be repeatedly reevaluated to see if they are responders in terms of complete biochemical response, incomplete or indeterminate, so that their TSH levels can be adjusted accordingly and the thyroid hormone dose can be adjusted. So this is the message that I think we would like to convey. And as I said earlier, these abnormalities are transient and they respond to treatment, but they tell us very important role of thyroid hormones in skeletal health. Thank you very much. We will then
Dr.
this,
Bipin sir, I think I would like to mention one more point here. I don't know whether that was clear. I had come across some data earlier that iodine also has some direct effect on the bone. Iodine excess in the countries where iodine excess has gone up, they used to have their reports that osteoporosis is higher. But I pardon, I don't have any latest knowledge about that. I don't know if you must have reviewed that iodine has a direct impact.
We look into that. I'm sorry, I also did not see this. So over to the organizers for caring further, Dr. Joshi and others.
Yes, sir. So special thanks to Bipin sir, Ashraf sir, and Dr. Amritava sir for this excellent session. So we now move on to a very fascinating discussion that is on thyroid and cognition. And to chair this session, we have with us Dr. Shashank Joshi sir. Sir needs no introduction. Sir is a very eminent endocrinologist from Mumbai. And we have Dr. Arun S. Menon sir, who is our secretary of ITS and also a senior consultant from Dubai. So joining them is we have Dr. Belinda George, who is the professor and head of the Department of Endocrinology at St. John's Medical College, Bangalore, as a speaker. So I request Dr. Shashank Joshi sir and Dr. Arun Menon sir to introduce Madam.
So first of all, I would like to thank Ganvi, you and Dr. Pramila for this entire initiative, and Dr. Krishna and the entire ITS team for continuing this educational activity on the World Thyroid Day. And I think our next speaker, Professor Belinda George, is the HOD of endocrinology at St. John's Medical College. She is a very accomplished speaker. She's the secretary of the Karnataka Endocrine Society. She is the medical superintendent of inpatient services at the St. John's Medical College. She has published extensively in areas of adrenal, gonad, pancreas beyond thyroid, and she's currently working on various agents of peripheral neuropathy in diabetes. But today her topic is brain fog or cognition linked to thyroid, which is a very pertinent problem, which is an emerging problem in this era, particularly in the post-COVID era. I think there is a lot of spotlight on the brain and thyroid. This was there in the beginning also, and it has come back again. So we are looking forward to listening to her. I would request Dr. Arun Menon to maybe say a few words, and then we can have Professor Belinda George, and then maybe have a short discussion. Thank you so much.
Thank you, Shashank. Good morning. As Shashank ji has said, this is a very important area because there's very little is known about thyroid and cognition. We know both hypo and hyperthyroidism can affect the brain, but the mechanism seems to be complicated. We know the role of thyroid in neuromodulation, but a lot of it is still very unclear. So I very much look forward to Belinda's talk. As we all know, she's a wonderful speaker. She's currently the HOD of St. John's. So over to you, Belinda, for your deliberation, and we'll take up discussion afterwards. Thank you.
Thank you. Thank you, sir. I'll just start sharing my screen. At the outset, let me also thank ITS and Dr. Pramila for giving me this opportunity. And also Dr. Shashank and Dr. Arun Menon for that introduction. Is my screen visible? Shall I start?
Yes, ma'am. Go on, ma'am.
Great. So today the topic is thyroid and cognition. Like our chairpersons have mentioned, this is a topic about which we do not know much. So let's see what, I'll just share the current data and what unanswered questions we have for the future. So when we talk about thyroid, we know very well it plays a very crucial role in overall metabolism and health from top to toe. It affects every organ of the body. And specifically when it comes to brain development and function, we know how important the thyroid gland is, as is evidenced from congenital hypothyroidism issues. And cognitive symptoms are often linked to thyroid imbalances, like we will see in the slides. This is just to show you how the HPT axis works. And though T3 and T4, they are the active hormones secreted from the thyroid gland, but the biologically active hormone is T3, which exerts its effects in the peripheral tissues. And this is controlled by starting from the hypothalamus, then the pituitary, and then eventually the end organ. So sometimes there is also a possibility that an insult to the brain can actually affect the axis, and sometimes the changes you see may be as a result of a neurodegenerative process, and at the same time abnormalities in thyroid can also contribute to neurocognitive decline. So this is just to show you how the thyroid hormones are broken down. T4, the very first molecule you see on top, is the main hormone. And then there are these enzymes called deiodinases, which break them down to either T3, or if it's T3, it is broken down to T2, which is inactive. So deiodinase enzyme is an extremely important factor in proper functioning of the entire thyroid axis. So if you have issues with deiodinase, again, T4 to T3 conversion at the tissue or the peripheral level may not be optimal, and hence it can lead to tissue level hypothyroidism. Similarly, if you look at the brain doesn't actually absorb the circulating thyroid hormones exactly like that. It is a T4 which enters the glial cells, and within that cell it is converted to T3, which is the active hormone, and then this T3 is taken up by the neuron as is shown in the picture. So if you have, and if you can see those little transporters which facilitate entry of T4 and T3 into the CNS system, you can see two transporters. One is called OATP and the other is called MCT8. So the OATP is essential for T4 to enter the glial cells, and then the MCT8 is actually sort of a rate limiting step there, because it is a single most important transporter which is essential for T3 to enter the neurons. So we do know MCT8 mutations or deficiency is associated with severe central hypothyroidism or severe neurological hypothyroidism, and has significant impacts on brain development and cognition. So it is not just the production of thyroid hormones, but it's also how it is peripherally converted and also taken up by the brain and the neuronal cells. All of this has an impact on how thyroid will have affect your cognitive function and normal functioning of your brain. So the other aspect is we have to look at degree of hypothyroidism. We all know that there is overt hypothyroidism and overt hyperthyroidism, wherein there is frank abnormality with the thyroid axis. And in these conditions, there is a clear association with cognitive decline, and there is also clear benefit from therapy. Now, we also have situations where the hypothyroidism or the hyperthyroidism is not completely overt, but it is subclinical, which means the thyroid function is normal, but it looks like there is some amount of stress based on the TSH levels. It's either too low or too high. There is some data to show that this also affects cognition, but this is a very controversial area. So we will look at some data pertaining to this in the coming slides. There is also the third aspect that I mentioned to you earlier, which is about tissue level thyroid sufficiency, specifically for the brain. We know from the MCT8 deficiency models that this has a significant impact, but what we do not know is what happens to these transporters in patients with either subclinical or, let's say, with aging, where cognitive decline is noticed. So this is to show you congenital hypothyroidism. So overt congenital hypothyroidism, we all know, is clearly associated with intellectual impairment. So there is no doubt that overt thyroid hypothyroidism should be treated. Overt thyroid dysfunction should be treated. And this, if caught early and treated, is completely reversible. So we should be treating this, we should be catching them early and treating. The other spectrum is what I mentioned, is the MCT8 deficiency syndrome. Again, these children have severe cognitive and neuromotor disability. And here the therapeutic options are limited because there is no problem with thyroid hormone synthesis or secretion. It is with uptake at the CNS system. So there are some analogs which we can use, but generally correcting thyroid hormones will not normalize. But it's a good model for us to understand the impact and importance of thyroid hormone normalcy within the brain. The other factor which is important is the onset. You know that congenital deficiency, which can be missed and can be picked only when the patient becomes grossly abnormal, has significant impact. Here, what happens is the thyroid is so essential for complete development of the brain. Whereas when we talk about an acquired deficiency, here you have a brain which is already developed. Here the impact is going to be on neuroplasticity, or renewing your synaptic connections and renewing your neuronal connections. Even in acquired deficiency, when it is overt and when it is for a long period of time, there can be significant cognitive impairment, and sometimes these cognitive impairments cannot be completely reversed to normal, which is based on the sparse data that we have so far. So onset of thyroid dysfunction, if it's congenital, screening is essential. You do not wait for them to become hypothyroid overtly, clinically have developed overt hypothyroidism before treating. Whereas for acquired deficiency, if you can shorten the duration from onset to diagnosis, that may have positive impact on the degree of cognitive decline. We'll also briefly look at what cognition is composed of. So cognition essentially is mental processes which are involved in acquiring knowledge and also being able to analyze that knowledge. So understanding through thought, experience, and senses. So basically, how we perceive the world. So the key aspects of cognition are perception, attention, memory, language, and problem solving. How do we assess what are the core cognitive domains? So we are very familiar with these terminologies, and when we do our MMSC, we usually cover most of it. So attention, which involves focus and concentration; memory, both short-term and long-term memory and working memory is important; executive functions, where planning, decision-making, and problem-solving is affected; language and visual spatial skills is also one of the cognitive domains. And lastly, processing speed. What is the mental quickness in performing tasks? So most of them we assess to some degree in our MMSC. However, if you look at factors which affect the cognition, our cognitive ability, or even the cognitive decline over time, you can see that age is one of the most prominent factors. And we know that as we age, our cognitive ability reduces slightly over the years. Of course, there's also other genetic factors which predispose to it. Then there are medical conditions like, trauma to the brain, beetle deficiency, psychiatric disorders. And among the medical conditions, thyroid dysfunction is one of the top contenders because this is an easily identifiable, treatable, and reversible cause for cognitive decline. So I don't think there should be any doubt that when you see somebody with cognitive decline, there should always be a screening for thyroid test. And if you detect any overt thyroid dysfunction, that has to be addressed. Other factors affecting cognition are sleep, diet, exercise, stress, and also toxins, which can again have a bad impact on the neurons. Then, of course, there's educational and environmental factors, which are to some degree non-modifiable. So what are the assessment tools that we have? Largely, it is based on clinical interviews. There is a lot of subjectivity in all these scores, which is one of the drawbacks of how we assess cognitive function. And then, of course, if you have a good psychiatric unit, they will do a detailed neuropsychological evaluation across all domains. But that is truly not possible in clinical practice. It's largely for research. And also, there is upcoming functional MRI scans, which can look at specific areas of the brain that we are interested in. Again, largely a research tool. So if you look at what we can use in clinical practice on a routine basis, we only have these small screening tools, which again is not so easy for a busy practitioner to conduct on every patient. Now we will look at what are the cognitive effects of hypothyroidism and hyperthyroidism separately. So in hypothyroidism, the large impact is on memory. Of course, everything is slowed down. Patients are predisposed to depression. Then, of course, there's severe fatigue and lack of concentration. And these factors are more severe in untreated and also in chronic cases who've been hypothyroid for a long time. If you look at cognitive effects of hyperthyroidism, you will see somewhat the different spectrum, which is largely related to anxiety and depression and impaired attention span, irritability, and insomnia, which again can lead to fatigue, lack of concentration, etc. And as a result of all of this, you may end up with cognitive decline. What are the mechanisms? I'm not going to elaborate on mechanisms because these are largely postulated and speculated mechanisms. So some of the mechanisms mentioned for hyperthyroidism is reduced cerebral metabolism, like occurs in every other organ. There are altered neurotransmitters, your serotonin, dopamine, etc. are affected. And there's also, like I mentioned earlier, impaired synaptic plasticity. When we talk about hyperthyroidism, the mechanisms are overstimulation of CNS and increased excitatory neurotransmitters, which ends up leading to anxiety and tachycardia and insomnia, which eventually ends up causing fatigue and cognitive decline. So if you take a look at, just summarize what I've mentioned so far, in infants, usually you will see congenital hypothyroidism, and there is clear intellectual disability if you do not recognize and treat it. In adults, on the other hand, because the brain is already fully developed, you're not going to have mental retardation or stark reduction in IQ if you diagnose the patients later, or the patient is having overt hypothyroidism, but what they're likely to have is mild cognitive impairment and a lot of mood issues, like I mentioned earlier. In elderly who are much more susceptible to this insult, this may mimic dementia. So particularly in elderly, overt hypothyroidism and B12 deficiency should be looked for because they are reversible, treatable causes for dementia. So how do we assess and treat for therapy? Assessment is very simple. As far as thyroid tests are concerned, you do TFT, simple TSH, if possible, get the FT4 along with it, and appropriate therapy if you have detected overt disease. There is no confusion with regards to that. There are some questions which linger on. One is, and we will try and address them in our in a couple of slides. The one question is, should all subclinical thyroid disease should be treated, whether it is hyper or hypo, because these diseases can also cause cognitive decline, and hence should we always keep everybody's thyroid status in the optimal state. Should thyroid testing be done in those with cognitive decline? Should formal cognitive assessment be done in all cases in routine clinical practice? And the most important question, because I think that a lot of us face in clinical practices, patients who have overt thyroid disease who are corrected, and biochemical restoration of euthyroidism, does it correct the entire prevailing cognitive impairment. So some of them we don't have answers, but we will try and look at what data shows us. So first, let's look at the link between thyroid disease and risk of dementia and cognitive impairment. This is a systematic review and meta-analysis published in 2024. You can see that they have searched for all possible permutations and combinations. They have landed up with 9 studies with clear, adequate amount of data. So here you can see the 6 studies which showed hypothyroidism. And you can see that in hypothyroidism, it is sort of split. 4 says that yes, there is a clear association, whereas 2 studies did not show the link. In fact, the 3rd study also was just touching the line of unity. So plus minus significance with regards to association and cognitive impairment in hypothyroidism. Whereas if you look at hyperthyroidism, you can see that clearly all of them said the risk of higher cognitive decline was higher in patients with hyperthyroidism. So this study concluded that, the relationship is actually complex and ambiguous. 6 out of 9 articles found that there was a specific link, whereas 3 articles refuted the link. And the 3 articles that refuted the link were all articles that looked at hypothyroidism. And one study from this was from India, which looked at subclinical hypothyroidism, again, which did not find a link between thyroid dysfunction and cognitive impairment. So since I think subclinical hyperthyroidism, we know there is an association, and majority of the time we address that subclinical hyperthyroidism in most patients. So I think we have to try and answer whether there is any role in addressing subclinical hypothyroidism in patients when we find them. Particularly important in older adults, because that is where the TSH increases with aging. So there is a lot of controversy or debate regarding intervention in patients in older adults with subclinical hypothyroidism. So this is the TRUST study. This is one of the largest RCTs which was done to address this issue. And you can see that half of them, around 190 in each group, half of them received levothyroxine. You can see that TSH was normalized and kept between just above 3 throughout the period of follow-up. And if you look at the outcomes, you will see that there was hardly any change with regards to cognitive outcomes. In fact, one of the health-related questionnaires slightly worsened in the treatment group initially, but it normalized later. So overall, the conclusion was that levothyroxine supplementation did not provide any apparent benefit in patients with subclinical hypothyroidism, including in their cognitive domain, which was addressed in this study. The other question that we repeatedly hear, and particularly with all the hype around T3 being available now, is in patients who are already receiving levothyroxine for hypothyroidism, because we know that levothyroxine is not the answer for the brain fog that you are perceiving. So will adding T3 mitigate some of these effects? Again, this is another SRMA, which has looked at combining versus T4 monotherapy alone. I'm only going to show you the combination T4, T3 and not the desiccated thyroid extract. So again, if you look at the scores here, they did not specifically look at cognitive domain alone, but they looked at a lot of thyroid specific questionnaires and health related questionnaires and depression scales, and found that there was no difference whether the patient was received T3, T4 combination or only T4 and achieved biochemical euthyroidism. So at the moment, we do not have any data to show that adding T3 is going to have any beneficial impact on brain function. Remember, if you remember the original picture that I showed you in MCT8 deficiency and the transporter issues in the brain, when neuronal uptake of thyroid hormones are what is impacted, you will notice that giving T3, if at all there is a problem, by giving T3 is not going to correct that problem. So again, similar to that thought process here, they did not find much difference in replacing T3, T4 together. So some of the probable explanations why there's so much controversy and there's so much confusion regarding cognitive impairment and thyroid. One reason, of course, is like I told you, our tools for assessing cognitive function is not very robust. It's not always objective. It's not standardized among all the various studies that have been done, which has led to some studies being positive, some studies being negative, and some studies being neutral. So objective standardized assessments looking into specific domains which are affected in hypothyroidism or hyperthyroidism will probably be more beneficial if you have to standardize and look at data uniformly across patients with thyroid dysfunction. So it might be helpful if we can develop thyroid specific tools over time. A lot of these are clinical interviews conducted with patients, and some of the scores are patient reported outcomes. And these patient reported outcomes are prone for significant bias. And so there is one study which looked at, when the patients self-registered and reported their scores before they knew their thyroid hormone status, like they've given for testing and they've answered this, and patients who knew that they were hypothyroid, they were suffering from hypothyroidism, there was a stark difference. Patients who didn't know that they suffered from hypothyroidism had scores very similar to clinically, biochemically euthyroid individuals. So maybe the impact on yourself that, when you realize that I have a thyroid dysfunction itself can affect particularly patient reported outcomes. So that is an inherent bias which is present in some of these tools. And on the other hand, there maybe it is not universal. This impact may not be universal. There may be a subset of patients who genuinely require some sort of additional therapy. Because remember, like I told you, the T3 is the active hormone, and T4 to T3 conversion across all organs occurs in a very tissue at the tissue level. So if you have a polymorphism in this deiodinase enzyme, the type 2 deiodinase enzyme, particularly that is the only enzyme that is responsible for conversion of T4 to T3 in the brain. Again, you will not get proper adequate conversion, and so there is tissue level hypothyroidism, which may be manifesting as brain fog in a subset of these individuals who have this genetic polymorphism. In the meantime, are there other factors that could also be modified to improve the brain fog that our patients are feeling? For instance, we all know that cognitive decline and cognitive dysfunction is associated with all of these functions: sleep, exercise, nutrition, and stress. This is what I'd like to call the sense. So sometimes a thyroid dysfunction may be just a bystander. A mild thyroid dysfunction is present, but the patient is not exercising, diet is not okay, sleep is not adequate. So do we have any data which has looked into it? So this is one study, which an RCT, which looked at impact of exercise training in women with subclinical hypothyroidism. This, of course, did not look specifically at cognitive function, but it looked at other quality of life indicators. And you can see that overall, there was a lot of benefit reported in women who were randomized to receive exercise training and continued that. I think this draws attention to the fact that just because there is a mild elevation in TSH, we don't have to forget other modifiable factors which can have a positive impact on our patients as well. So I will go back to the questions that we asked and see whether we could get answers to some of them. Should all subclinical thyroid disease be treated? The answer is, I think for hyperthyroidism, all of us address, particularly in the elderly, and like the previous talk mentioned, it's good for the bone, it's good for the heart, for erythemias, so it's also good for the brain. So I think subclinical hyperthyroidism most of the time will be addressed. Whereas when it comes to subclinical hypothyroidism, it is not very clear. The evidence is not very clear. We know that subclinical hypothyroidism is associated with cognitive decline, but whether this association has a truly causal relationship or not is very, very confusing. It's very doubtful. We do not have enough data to convincingly say that this is causing it, or even vice versa, so we should treat. So that data is not there yet, and maybe future research will throw some light to it. Should thyroid testing be done in those with cognitive decline? I think the answer to this is very clear, yes, and we already do that in clinical practice. The only doubt is if we end up identifying a subclinical hypothyroidism, is there any sense in treating the patient? Again, that is a gray area plus minus. Should formal cognitive assessment be done in all cases? Because we know that subclinical hypothyroidism, you assess them, and if you find that there is cognitive impairment, is that an indication to treat? So again, here, there is no clear answer. Currently, there is no reason to treat subclinical hypothyroidism just because there is mild cognitive impairment that may not be caused by the subclinical hypothyroidism, so we don't have to treat it. And doing formal cognitive assessment in clinical practice is a huge challenge, so it may not be possible for all of us to do regularly. And will treatment of overt disease correct the prevailing cognitive impairment completely? I think this is an unanswered question. a lot of our patients who have achieved biochemical euthyroidism continue to complain about brain fog or persistent fatigue. Some of the patients have opted to receive try out T3 along with T4, and some of them report subjectively feeling better, but objectively looking at data, there is no clear evidence to say that adding T3 will mitigate this. So this is an area which needs more research. Is there some tissue level hypothyroidism going on? Is there something we can do to address it? So this is something for the future. So in summary, there's lots of controversy about the true impact of mild or transient thyroid dysfunction on cognition. There might be a specific subset of individuals who are susceptible to this and they might benefit from whatever intervention we can. Currently, correcting thyroid status biochemically alone, though it might be insufficient from patient's perspective, that is all we can offer for now as pharmacotherapy based on recommendations. There is no role for trying anything else currently. However, the sense approach might be worthwhile because no one's going to lose anything by improving their sleep, exercise, nutrition, and stress. So that might make a positive impact and a difference to our patients. Thank you. I'll end with that.
Thank you, Dr. Balinda, for a very wonderful presentation. And I'll request Dr. Arun Menon to make any comments. But Belinda, you tried to do a very nice narrative on what is available in the current literature on this very difficult topic. I had only two comments on it. One is the antibodies and depression and psychiatric disorders. A lot of our psychiatric colleagues often use thyroxine as an adjuvant. And maybe you could just maybe make a passing reference to that. Though the topic was cognition, a lot of psychiatric disturbance and depression is often associated with autoimmune thyroid disease, often subclinical. So that's a gray zone. But I think you, on the cognition part, I think you were able to present all the evidence base which was there. And I think you also re-emphasized the value of sense, which is the nutrition, exercise, and overall stress management. So I think it was a nice presentation of a very hot topic. This topic is more on the social media and less on the evidence-based side. But it's time that, as Krishna was saying, we need to do more research in this area. This is worth looking at, doing some research. Arun, maybe you will have a couple of comments and questions, and then maybe Belinda, you can take a quick comment on this odds ratio of antibodies, depression, and psychiatrists using thyroxine as a adjuvant.
Thank you, Shashank. I was just going to add to that comment that you made. I think Hashimoto's encephalopathy, an entity which is perhaps controversial and nobody knows what actually it means, and the role of antibodies. I think we get a lot of referrals, isn't it, especially from neurologists, where they say, "Oh, will they improve if we give thyroxine?" So we know there is an autoimmune etiology does it? An autoimmune etiology can worsen cognition in many other autoimmune disorders. So is there any link that autoimmune thyroid disease, as Shashank was asking, has increased chance of cognition in thyroid disorders, those with autoimmune disorders? So I think that is something which we can discuss. Over to you, Belinda.
Yes, so I think Hashimoto's encephalopathy is an accepted diagnosis in neurology circles. But when it comes to us, we find it really difficult to accept it because as far as we are concerned, the patient is already euthyroid. And then it is just the antibodies which is being used as a causative agent for the entire neurological dysfunction. And anyway, the therapy that neurologists provide is steroids. It's considered as a steroid responsive encephalopathy. And when we get references from neurologists, what we do is we look at the thyroid status, we ensure that the patient is euthyroid. And if the patient is euthyroid, then the decision to treat with steroids or not and look for response is left to the neurologist. And most of us consider that this is probably just the antibody positivity is probably just an epiphenomenon. It's probably autoimmune encephalitis, and it's just that a bystander, the TPO antibodies are just bystanders, which is being detected as a surrogate marker of autoimmunity. Coming to AITD and cognitive impairment, I will have to tease it out and look at it. I'm not sure whether there is any evidence to say that AITD per se has worse cognitive impairment compared to others. But most of the studies have done in post-op patients, post-thyroidectomy status, and that is where they have found that treatment dissatisfaction is very, very high among patients with who have achieved biochemical euthyroidism. Whether autoimmunity per se adds another element of thyroid cognitive dysfunction is something that I'll have to look into. With regards to depression, yes, I think if the patient is suffering from depression, we all have a low threshold to treat thyroid dysfunction, whether it is overt or subclinical, because whatever correctable factor is there, we should try and normalize or make the patient biochemically euthyroid. On the other hand, when we talk about psychotic illnesses, we generally don't address subclinical disease because of non-thyroidal illness syndrome, there can be a lot of changes in the thyroid function tests. Whereas if there's frank depression, we always correct whether it's overt or subclinical. That's all I have to say, sir.
Thank you. Thank you so much. I think, Arun, if there's nothing else, I think we are woefully late. Once again, I congratulate Pramila and Ganavi for this wonderful World Thyroid Day meeting and everybody here. And I think Balram's team is all waiting for the panel discussion.
Thank you. Thank you, Belinda.
Thank you, Shashank sir, Arun sir, for chairing the session, and Madam for her explicit presentation. Pramila ma'am has a lot of publications with this regard as well, that is thyroid and cognition as well. So moving on, we now have a very highly anticipated panel discussion that is on approach to thyroid nodules in pregnancy. The session will be moderated by Dr. Balram Sharma sir, who is the professor in the Department of Endocrinology at SMS Medical College, Jaipur. And as our distinguished panelists, we have Dr. Divya Dahiya Madam, who is the professor and Director of Endocrine and Breast Surgery at PGIMER, Chandigarh, and Dr. Ritesh Agarwal sir, who is an endocrine surgeon at Leelavati and Saithi Hospitals, Mumbai, and Dr. Neeti Singhal ma'am, who is the consultant pathologist, senior consultant pathologist at Medanta, Lucknow. So over to Dr. Balram sir to introduce the panelists and to moderate the session.
Thank you, Pramila, and thank you, Dr. Ganavi. So can you share the slides of the introduction of the panelists?
Balram sir, I think we shall go ahead with the panel discussion.
Okay.
Yeah.
Okay. So already the part of introduction has been done.
Yeah.
So to save the time, we can directly proceed for the panel discussion. So in continuation to the discussion and clinically very pertinent and important discussions, what we have just started a couple of hours ago. So this is very important aspect that whenever we look at any thyroid nodule, then there are various challenges in diagnostic as well in the management strategies. But things becomes quite complicated and more complex if we are dealing those issues in the pregnancy. So there are a lot of discussions that has to be done. If we look at the thyroid nodules, they are quite common. And if we look at the different literature available to us in terms of the clinical examination, particularly the palpation, then the reported evidences of thyroid nodules are nearly up to 5 to 7% in general population. And the thyroid nodule incidences are typically reported more in those areas where iodine deficiency is there. But if we look at the recent literature where the utility of ultrasound, like the thyroid ultrasound, it has increased now. And if we look on those data, then the chances of detection of thyroid nodules are pretty significantly increased. And the prevalence up to 50% of patient might have some or the type of thyroid nodules. But despite this high prevalence of thyroid nodule on the ultrasound, the detection of thyroid cancer is not that common. And that still seems to be quite uncommon entity. But if we look at the pregnancy, there are certain data or literature available that shows that because we know that thyroid is facing a lot of physiological stress during the pregnancy, or we can say that pregnancy is in a state of thyroid physiological challenge or stress. And because of various changes in the hormonal or metabolic changes in the pregnancy, there are reports that probably it might have some impact on thyroid nodule or in development of neoplastic cells also, although it is still controversial So we will be discussing with those esteemed panelists about those all questions practically we face during the diagnosis, during the investigation, during the management or clinical evaluation. So we have the pathologist, we have two esteemed and very senior endocrine surgeon also. But we know that in pregnancy, it is more common to have medical consultation, and frequently, even those patients who are quite negligent in the routine practice or routine life, they have more consultations in the pregnancy time. So this is more common also to get detection or the diagnosis of thyroid nodule during the pregnancy. But at the same time, that causes a lot of anxiety also. And we frequently have those referral or references from the gynecologist, from various other specialties, sometimes the patient by themselves also. The doctor, I have this problem, and is it alarming or is it having some malignant potentials? So the main focus has to be that we have to rule out the malignancy potential or the risky profile or the simple, we have to differentiate between these two. And although, as I mentioned, that thyroid cancer is not that common in the overall thyroid nodule scenario, but still we have to accept that it is one of the commonest malignancies that can be diagnosed during the pregnancy, including the breast malignancy and many more. But there are various challenges during the pregnancy in terms of diagnostic strategies, in terms of therapeutic options, like the radioiodine scanning, like the ablative options, like the surgical options. So there are various challenges during the pregnancy. So I will request Dr. Divya Daya to please share. Commonly, do you see the thyroid nodule in pregnancy as well in normal females? Means we wish to discuss about the prevalences in the clinical scenario or in the pregnancy particularly. How common is they are in your clinical practice as well in literature? Over to you, ma'am.
Ma'am, you have to unmute, ma'am. Divya, ma'am.
Yes.
Yeah.
Please unmute, ma'am.
Sorry, as you have already mentioned, the thyroid nodule incidences, clinically detected nodules are 5 to 7% only. But when we do imaging, the incidence goes above 50, up to 60, 65%. And in my clinical practice, in pregnancy, we have more incidence of hypothyroidism, and very little patients come with the nodules. And so I cannot tell you the exact percentage in my personal practice, but overall in literature, the incidence of thyroid nodule development in pregnancy is well documented, and increase in the size of pre-existing nodule is also well documented.
Dr. Ritesh, would you like to add something?
Yeah. First of all, I would like to thank the Indian Thyroid Society and the whole organizing committee for making me a part of this grand venture. So, as you already said, in pregnancy, even if the patient is having a thyroid nodules or any other thyroid problems, most of these patients land up with the endocrinologist rather than endocrine surgeons. So it is the endocrinologist who see thyroid nodules more often and do a proper evaluation and workup. However, it is a well-known fact that during pregnancy, there's a slight increase in the proportion of the thyroid nodules due to multiple factors, like under the effect of estrogens, under the effect of beta HCG, and also there's differences in the normal ranges of TSH. The beta HCG acts as a TSH simulator, which increases the proportion of thyroid nodules. So a bit increase is there in the incidence of thyroid nodules. However, it is not very much alarming. And I still would like to say that the evaluation in pregnancy is more or less same as compared to the normal patients when they come with the thyroid nodules. Sonography being the mainstay, evaluate the patient with sonography. As we all know, definitely some things are contraindicated. Shall I continue, or will you ask the questions later and I will inform them?
Keep on discussing. Dr. Niti, will you like to add a few more points?
For good afternoon. For thyroid, the
follow-up for nodules is more or less same as that for a non-pregnant lady. And the basic aim for diagnostic strategy is also the same, that is to distinguish between benign and malignant. And of course, the starting thing is a clinical examination, whether the patient has any family history, whether any radiation or any drugs she has been taking or she has been operated upon. And of course, the clinical symptoms of the patient, whether she first presented as an asymptomatic thing or whether she presented with any voice change or any difficulty in breathing or any particular lymphadenopathy, etc. So that clinical examination is the first key. And then later on, the systematic approach is as for any other thyroid nodule, except of course the scintigraphy and PET, CT, etc. are contraindicated during pregnancy. Thank you.
Perfectly, Dr. Nidhi. So to sum up whatever we have just discussed, that during the pregnancy, we have various challenges like the level of estrogen is increased, like the level of HCG is increased, and at the same time, there is relative iodine deficiency also in the pregnancy, and those all causes a lot of stress on thyroid, and the chances of development of thyroid nodule or in size in whatever existing thyroid nodule might be increased. This is for sure that the level of concern or level of anxiety is pretty high in comparison to the normal population. As rightly mentioned, that it is pretty important to focus initially on the clinical examination and proper history, because if she has any history of family history of malignancies, particularly those main syndromes or thyroid malignancies or like surgeries or radiation exposure, then definitely the chances of the nodule, whatever we are trying to diagnose, might be a little different from a normal one. So there are evidences that even iodine deficiency is more, and if you replace iodine properly during the pregnancy, and we know that the recommended doses of iodine are more in pregnancy, and that is up to the range of 250 in comparison to the 150 normal female, and that's how we can try to reduce those chances if it is possible. So looking at the clinical aspect as well on the diagnostic strategies. So Dr. Divya, I will like to request you to answer about the possible diagnostic strategies, like the clinical examination, first of all, then the routine evaluation of TFT, TSH receptor antibodies, and then the radiological aspect, and about those other FNAC, and those I will be discussing with the pathologist.
Dr. Balram, the clinical, how we approach a patient is not different whether the patient is pregnant or a non-pregnant lady. So it is first the clinical history with the patient, with which the patient has presented to us, whether it's a simple nodule or it is having associated hypo or hyperthyroid symptoms or any pressure symptoms. These are the three things which we are always interested in any patient who comes to us with an neck swelling. Similarly, when we examine, our aim is to see whether it's a solid single nodule or it's a multinodular goiter or any compressive compression if we can document on our clinical examination. After that, we do two investigations. One is the thyroid function test. The TSH is the most important, and the ultrasound neck. And based on the findings of clinical suspicion or ultrasound findings, we decide to proceed further with the FNAC or not. If there are high suspicions of malignancy on clinical examination or the history, or based on the ultrasound thyroid scoring, we always advised FNAC, and based on the report of the FNAC, we decide further whether to advise surgery as an emergency or we can wait till the time patient delivers the baby.
Yeah. Dr. Ritesh, so what are those points when we used to decide for the FNAC depending upon the USG findings? There are certain pointers which suggest that the chances of malignancies are more in comparison to those simple pointers. So would you like to focus upon those?
Yes, sir. Definitely. See, sonography is a very important investigative tool, either in the non-pregnant or pregnant patients. And the same sonography features can guide whether the nodule is more likely to be a malignant or not, like hypoechogenicity, microcalcifications, irregular borders, increase in the color flow in the nodules as well as peripheral vascularity. Also the presence of lymph nodes, and if they are cystic or globular lymph nodes with microcalcifications, there are high chances of malignancy. However, I have one reservation in terms of doing FNAC in pregnant patients, because suppose if let's go as a clinical basis. Suppose if the nodule is small and the patient is pregnant, then even if it is malignant, what is the urgency of treatment?
Exactly.
So yeah. So if I'm going for FNAC or if the nodule is looking malignant, I would like to prefer more here, especially in pregnant patients, core needle biopsy as compared to FNAC. It is very important to give the exact diagnosis. FNAC will give many times only malignant cells. Sometimes, especially when the nodule is harboring a lymphoma, which gets quietly aggravated during pregnancy, and becomes an emergency condition. So, to differentiate certain types of malignancy, core needle biopsy is more important as compared to FNAC in pregnancy. In other patients, I don't prefer core needle biopsy, but in pregnancy, definitely yes. If the nodule is looking malignant or having a higher chances of malignancy based on Thyroid scoring on the sonography, I would recommend core needle biopsy here.
So, Ritesh, you mean to say that in place of FNAC, you wish to do the core needle biopsy, or when the suspicious finding on FNAC are there, then only you are going to proceed? Means
if the higher Thyroid grading like Thyroid 4, Thyroid 5, then I would like to prefer a core needle biopsy.
In place of FNAC?
In place of FNAC.
In remaining all other cases, you wish to go for
yes,
the
definitely.
FNAC?
Yeah.
Dr. Neeti, your take on this particular entity, because you are pathologist?
So in our institution, we do FNAC only. So I don't have much experience with core needle biopsy being done in pregnant ladies. But yes, for anaplastic carcinomas and high-grade malignancies, core needle biopsy is routinely performed. And also the material definitely is much more. And you have material for further molecular testing as well, if you have a proper biopsy sample.
Okay. So actually, we have to differentiate.
May I add one point, Dr. Banga?
Yes, please.
I differ with Dr. Ritesh a little bit. Like FNAC, we advise when either there is a clinical or there is a radiological suspicion. And majority of these tumors are like the differentiated tumor only. If still we can pick up the anaplastic carcinoma or lymphoma, which is very rare in thyroid, on FNAC. Based on the report, we can further decide whether to go ahead with the biopsy or what kind of treatment we are going to offer to this particular lady, rather than to subject to biopsy to each and every woman who comes to us. Second point, I would like to say, like, even if we know it is a malignant nodule and it is based on the history and examination or the absence of lymph nodes, our preferred treatment will be to wait till the term. But to say we will not characterize the lesion despite of having high suspicion means I differ on this point. My decision may be different whether to operate during second trimester or to wait till the term. But still, I would like to characterize the lesion whenever I have a doubt clinically or radiologically.
Exactly, ma'am.
I'm also saying the same thing, that we have to characterize the lesion. We have to ascertain the diagnosis and then only plan the treatment, whether to operate in emergency in second trimester of pregnancy or we can postpone the surgery after delivery. There's absolutely no doubt about it. But if the features of malignancy are there on sonography, then definitely I would like to find which kind of malignancy we are dealing with. My point is that.
Okay, so that was the Ritesh perspective of management, and that seems to be valid also. But still, the standard guidelines recommend that if we have the suspicion, means a strong suspicion, then we can proceed in that manner. But the standard guidelines suggest that even if you have this suspicion and the size is less than 1 centimeter, then even there is no need for FNAC. And if the size is more than 1 centimeter, and the sizes for FNAC also. But in FNAC also, we used to see that inappropriate sampling, sometimes there is hemorrhagic samples, and we use. So Dr. Niti, I will like to take your opinion about that. What precautions we should take, because in pregnancy, whatever we are going to do has its impact on the patients as well in the family that she is undergoing some procedure. So we can ensure a good FNAC sample.
Yeah. So FNAC should be done in a proper setting with very experienced personnel. And if anything, I would say it should only be performed under guidance, ultrasound guidance. That is one of the most important things. And like routine, it is no different in a pregnant woman. Any trimester, you can perform the FNAC. And in routine setting, it will be depending on whether the nodule is cystic or solid. And if it is cystic, then we typically aspirate all the fluid and then hit the solid area of that is most important, that we hit the solid area of the nodule. And also what we can do is prepare cell blocks. What we do here is that we collect the fluid in a vial, like a urine container sort of thing, a sterile container, and then prepare cell blocks, which can give a higher yield. And that material can also be used for this molecular testing as well. And then if we are expecting a lot of hemorrhagic sample, then it is better to perform a on-site assessment of the cellularity. So we typically ask the patient to wait for some time, and then we do a rapid stain and assess on microscopy whether we have enough cells or not.
And if there are inconclusive reports or indeterminate reports, then when to repeat the FNAC if it is required?
So we repeat it, not like the recommendations, few of the studies say that after 3 months only. We repeat them within a week, and multiple passes are taken. And but the problem with repeat is that you will have more hemorrhage. So the cellularity does not actually improve with with repeat FNACs. But yeah, under guidance and using rapid on-site. And then if we have hemorrhage, then we typically prepare a cell block. We don't go for just the cytology.
Thank you, Dr. Nidhi. So in continuation, we nowadays used to use the Bethesda grading, but there are certain grades which are indeterminate, and there are other pathological features also. So would you like to enumerate those points in addition to the Bethesda grading, which should be taken care by the clinicians, because we are not pathologists, that these points has to be taken to be noted, particularly when we are deciding the further course, because depending upon the ultrasound and depending upon the FNAC reports, we clinicians used to decide the further course, either in terms of conservative management or either in terms of surgical options.
The thing is that FNAC is not a standalone investigation. It will be, of course, in conjunction with the ultrasound findings. So we need the sonological findings as well when we report the FNAC. So main thing is that benign is benign, which is very clear cut. And malignant is malignant, again, which is very clear cut. So that it's bifurcated. Now the main problem arises in the intermediate categories, which is AUS, that is atypia of indeterminate significance, follicular neoplasm, and suspicious for malignancy. So here in the follicular neoplasm category, we cannot really help because that encompasses both benign as well as the malignant follicular lesions. So their FNAC will not be able to help at all. For that matter, even a core biopsy will not be able to help at all because we need to sample the whole nodule. And also, even in this setting, I must say that even the molecular does not help because the RAS mutations for follicular lesions are seen in both benign as well as the malignant conditions. Now, for the AUS category and the suspicious for the risk for malignancy is highest when it is suspicious for malignancy. And that we use most often for the papillary thyroid carcinomas or even medullary to some extent. And here again, the clinical management options is the molecular testing, and that is diagnostic molecular testing, lobectomy, or near total thyroidectomy. So this suspicious category has up to 83% risk for malignancy. And the atypia of undetermined significance is now divided again into the other and the nuclear atypia category. And nuclear atypia also means the features for papillary carcinoma, which are present in a few cells, but all the findings which favor papillary carcinoma are not there. And here also the same methodology for repeating FNAC, molecular testing, diagnostic lobectomy, or surveillance. Either of these are the thing. But the thing about AUS is that in pregnancy, it would mean like a differentiated tumor. So the differentiated tumors are not typically surgically intervened whether during pregnancy.
We will be discussing those in the next few slides. But Dr. Divya, I would like to request your suggestions about the odd situations when we have the discrepancies between the Thyroid's grading as well in the Bethesda grading. Sometimes the Bethesda is showing stage grade 2 or 3, while the Thyroid is showing 4 or 5 or opposite also. So what is your take, Dr. Divya, Dr. Neeti, and Dr. Ritesh about those discrepant situations?
If we think, like we are discussing this kind of situation in pregnancy, as Dr. Neeti has already mentioned, most of these indeterminate nodules very difficult to characterize. And even if they are harboring malignancy, normally it is differentiated tumor and has a less aggressive kind of tumor. So it is always advisable that one should wait for the term and then subject the patient to surgery, which will be diagnostic as well as therapeutic. Because molecular testing, as ma'am has already mentioned, it is not sensitive and it doesn't give us any more information which is specific for the malignancy.
Yeah, so that typical 7-gene panel, what we used to do is not that sensitive. Recommendations or guidance also suggest that those BRAF mutation, RAS mutation, PAX8 or PPAR, gamma, and RED, PTC, these are those 7-gene panel which we use to practice. But still, the confusion cannot be cleared totally depending upon the molecular analysis, but still there might be some additional information. If they are positive, then things might be a little different, but still you cannot be 100% sure. Dr. Ritesh, your take about this particular entity?
Sir, if in pregnancy, if there's no urgency, then it is absolutely no reason to keep on lingering with further testing, say, when that, even if it is small nodules, thyroid, say, grade 4, FNAC, grade 2, 1, 2, or 3, because we are not going to treat anything further. So let the patient deliver peacefully, and then we can take further testings or further treatment if require surgery, and if require conservative approach based on further testing, but not in pregnancy. If it is FNAC 1, 2, absolutely there's no urgency to treat anything. Unless it is life-threatening or unless it is causing severe compression of trachea rather than a mild compression, which can be easily tackled during whole pregnancy.
Perfect. So the panel has clear-cut consensus that if the things are like not serious, we can wait and watch and go ahead with the pregnancy delivery, and after that we can decide about those options. But Dr. Ritesh, what are those situations where we have to decide about the urgent surgeries like the anaplastic malignancy, although they are very rare, the compressive symptoms you rightly mentioned, or those situations where we have to decide about the surgery, particularly in the second trimester or even in the earlier trimester?
Yes.
And what are the pros and cons of doing that, those surgeries in the first trimester, second trimester, or after the delivery?
So we should understand one fact: thyroid surgery is not an emergency. So if there's no emergency in pregnancy, we should not contemplate any thyroid surgery. But if there are emergency, definitely there are like severe tracheal compression leading to breathing compromise. Patient is having fall in saturation of oxygen persistently, and patient is having sudden increase in size of the thyroid nodule, which is going in the mediastinum. Here we have to judge that whether we should go ahead and operate now, or we can wait and watch till the whole pregnancy is over. Also, if the patient is having, see, you told anaplastic. Anaplastic usually occurs in the old age rather than in a pregnant females. So we should not think about anaplastic, but yeah, other
Definitely
malignancies
it is
like,
rare.
yeah, it is rare.
Definitely it is rare, but if it is diagnosed like MTC or anaplastic, then what are those?
MTC definitely, yes, we can find in pregnancy. Lymphoma definitely, yes, we can find in pregnancy. So lymphoma, we have to go for a perfect diagnosis by core needle biopsy and then treat accordingly as early as possible. Here, lymphoma is more important as compared to pregnancy. So whatever trimester the patient is in, but if the diagnosis of lymphoma is certain, then a patient has to accept that termination of pregnancy may be the option to save the life of the patient, because chemotherapy is urgency here. Second thing, if it is medullary thyroid cancer, but still no urgency, the calcitonin is less than well below 100, and the nodule we have observed it is slow growing, or there's lymph nodes are not there, no urgency for surgery right now. As soon as pregnancy or delivery is done, we can plan for surgery.
Dr. Dipya, so there are a lot of information now coming in terms of the discussion between the options of laparoscopic surgery versus the open thyroid surgery. So if we have to decide, like we have just discussed that we should follow up, but still if we have to decide, or we have decided that this patient should be undergone to surgery, particularly in second trimester or whenever that is required. So what is your take about the laparoscopic versus the open surgery options, particularly in this thyroid nodule strategies?
Actually, the thyroid surgery, it is whether you are doing open or laparoscopically, it is the skill of a surgeon and the scar for the patient. So other than that, it doesn't add any extra advantage. So if the surgeon is competent, they think they can finish up the surgery early, then it is the decision of the patient whether they want laparoscopically or open. But if the surgery is going to take time because the experience is not that much, in that case, I will say better to do a short surgery by open procedure.
In terms of the side effect profile or the complication, particularly like the hypopara, so the same is the results if according to the competence of the surgeon.
Yeah, it is all the competence of surgeon. Even in open surgery, if the surgeon is not trained enough or doesn't have enough experience, they have more incidents of nerve injury or hypocalcemia. So it's
So
all for experience, yeah.
In comparison to the general surgical options where the laparoscopy is more preferred in nowadays, in thyroid surgery, still the open surgery is better option.
I will say the same for the other surgeries also. It is your competence. Like even if you are doing colectomy, you can take 10 hours, you can finish in 1 hour. So it is not like it is again the experience of a surgeon, how quickly they can finish the procedure.
Okay. So the panel is clear-cut consensus that we should try to stay more on the conservative options if it is possible until proved otherwise, except in few situations like the anaplastic surgery or the compressive symptoms or very risky features of life-threatening dangers to that particular patient. Otherwise, we can wait and watch and follow up because nothing wrong is going to happen even if we are following up this patient. And the same is the standard recommendation of various guidelines as well the literature available, that even if we are following most of the PTCs, if the size is less than 1 centimeter or less than 2 centimeter even, then the chances in the overall prognosis are not going to be worsened, even if you are following up with the patient. But you can take the decision according to the patient's perspective. Ma'am, would you like to share your experience about the post-surgical hypopara incidences, and if you have particular experience in the post, like in the pregnant situations?
Actually, personally, I have never operated any pregnant female like during the second trimester. So I won't be able to give you my own experience.
Okay.
So our advice to them is if to wait till the time they deliver the baby, and after that only we do the surgery. So
Ritesh,
I
would you like
cannot
to add?
give you my own experience.
Certain families where I operated, I gave them the option to complete the pregnancy, deliver the baby, and then come back. But unfortunately, patients got MTP done, and then we operated.
Okay. Okay, ma'am, in short, because we are having lack of time, about the post-operative like follow-up in the postpartum period, or one if we have followed with the conservative management, then how to do in the postpartum period. Just in short, Dr. Ritesh and Dr. Divya, please.
It's almost the same protocol as we do in the non-pregnant patients. Same protocols, do the regular serum calcium testings, Q4 PTH if it is feasible for the institute, and then give the calcium tablets as required. Thyroxine supplementation should be started early because we are not going to treat with iodine during the whole pregnancy.
Yes.
Iodine can be given after surgery, after delivery. So start the thyroxine next day only after surgery in the normal usual dosage to keep the TSH below 2.
Yeah, so this is very clear that the radioactive iodine is contraindicated strictly in the pregnancy. But once the pregnancy is over, then either the scans like the nuclear scan can be planned because they also are contraindicated in the pregnancy, as well the radioactive iodine ablation if it is required, or the iodine scanning techniques if they are required. And the literature suggests that if you have to use the radioactive iodine ablation, then preferably, and if it is possible, then preferably it should be done after the lactation is completed. At least 6 months of the lactation has to be completed. Otherwise, if there is urgency, then definitely you can go ahead with the RAI also. But preferably, it should be done after lactation also. And in the pregnancy, it is strict contraindication for sure. Dr. Neeti, would you like to add something?
Sir, about
because we are in the final stage of this discussion, and I will request each one of you to share your take-home messages or the final concluding remarks.
Yeah. So basically, pregnancy nodules in pregnancy are same to be dealt with in a different manner clinically. But as far as diagnostic approach is concerned, they are more or less the same as that for a non-pregnant lady. And FNAC as a procedure is very safe. And I would like to add that now WHO 2022 classification has added differentiated high-grade tumors. So there is a category of follicular carcinomas and papillary carcinomas which have a more aggressive features, which have more aggressive features. So my thing would be that we need to detect those, because it is not just in any other papillary carcinoma or a follicular carcinoma, it is a more aggressive. And the defining feature for this WHO category is that there should be mitosis with or without necrosis. So if we in a FNAC setting or a cell block or any biopsy, cold biopsy, in any of these conditions, if we see much more frequent mitosis, then we should report that it could be a high-grade lesion. And further to that, the molecular testing, which would be much more useful for triaging patients for a surgical or a non-surgical approach, would be the P53 mutation and the PIK3 mutation, because these are found in a higher grade of tumor. And so it is more important that these patients should be managed much more aggressively or much more early as compared to the rest of them.
Thank you, Dr. Niti. Dr. Divya, your final concluding remarks about today's discussion.
The ma'am has already summarized. I would like to say the surgery is indicated only if it's like a rapidly increase in the size along with the presence of lymph nodes, or there are compressive symptoms, or the pathology says it is an aggressive tumor. Otherwise, all thyroid malignancy the surgery should be delayed once, like it should be delayed, and it should be performed only after the delivery of a baby.
Thank you, ma'am. Ritesh?
Same.
Thank you, Ritesh. So to conclude with that, we have discussed about the thyroid nodules approach in pregnancy, and we know that although the thyroid nodule in pregnancy is little more common because of some hormonal changes, some physiological challenges, and more diagnostic strategies also being used in the pregnancy, but still most of them can be simply followed up without any intervention, without any significant management strategies. The only thing we have to focus on the aggressive lesions, although they are fortunately rare, but if they are there, then definitely surgical options can be tried upon, particularly in the second trimester. And if it is possible to follow with the conservative options, we endocrinologists used to follow with the conservative options also. So to maintain the TSH level well below 1.5 if it is possible. So the safe range is like little bit differences in the guidelines, but 0.1 to 1.5 you can safely maintain if you wish to follow whatever lesions are there, even if they are malignant. So do not need to worry, or we have to explain to patients that even with the malignant nodules, if they are not having those all risky features what we have just discussed, we can safely proceed with the conservative management strategies and safely complete your pregnancy, and after that we can decide. But yes, there are certain red flags like no radioactive iodine ablation in the pregnancy, no nuclear scans in the pregnancy, and regarding the FNAC USG we have discussed. Regarding the molecular markers, they might be of some help, but still more data is required to make them a clear-cut useful entities as of now. So that's all from our side. Thank you, Dr. Pramila. Thank you, ITS, for inviting us. And over to you.
Thank you, sir, for a wonderful discussion. Thank you, Balram sir, and all the panelists, especially for very engaging discussion. So now, as we approach the end of today's session, it is time to test our knowledge related to thyroid with a very fun and engaging quiz. So to moderate the quiz, we have Dr. Miniji Pillai, Madam, who is the treasurer of the Indian Thyroid Society. So it's my honor to welcome Madam. And the quiz will be conducted by Abomani Baro, Dr. Abomani Baro, who is the associate professor at Guwahati Medical College and Hospital at Assam. I request Mini Ma'am to introduce the quiz master for today's session.
Yeah, good afternoon all. I think all of us who have been listening to various aspects of thyroid disease over the past 2.5 to 3 hours have also almost become toxic, have acquired toxic levels of knowledge in thyroid disease. And quizzing remains a very popular and interesting method to assess knowledge in any aspect of medicine. So our quiz master for today, Dr. Abhamani Baru, I think she has been already introduced, Associate Professor, Department of Endocrinology, Guwahati Medical College, and also Consultant Endocrinologist at Pradiksha Hospital, Guwahati, Assam. So over to you, Dr. Abhamani, for today's quiz.
Thank you, Mini Madam. And these are the quiz rules. So to participate in quiz, click on the button, that is attend quiz button given on the screen, which is being live streamed. The quiz will be conducted through a platform called Slido. You are requested to use a laptop for ease of experience. Quiz will run for 5 minutes. The quiz master, that is me, will display case or description of questions by screen sharing a PowerPoint file. There will be 10 questions in total, and each question will be available only for 30 seconds with the timer on. Kindly do not refresh the page or go back onto the page. So now we will start the quiz. It's a very easy quiz and it's for everybody. So all the best, everyone.
Madam, I will give you the cue when to change the questions. You can share your screen for me.
Okay.
Yeah.
So I'm sharing the PPT. So the first question is, subclinical hypothyroidism is associated with all of the following except diabetes mellitus, option A, option B, dyslipidemia, option C, hypertension, option D, osteoporosis.
Madam, next question, ma'am.
Yes. So the correct answer is option D. So which of the following is not a risk factor for malignant potential of thyroid nodule? Is the second question. Option A, male sex. Option B, age more than 70 years. Option C, age more than 14 years. And option D, cervical adenopathy. I request all the participants, because of shortage of time, you can discuss your queries at the end of the session or at the end of the quiz.
Ma'am, next question, ma'am.
Yes. So answer is option C. Age less than 14 years and a pediatric age group is at higher risk of malignant potential. So the answer is option C. So now question number 3. Which of the following is not an indication for immediate FNAC in a patient with thyroid nodule? Option A, nodule 1 centimeter but TRADS 3. Nodule more than equal to 1.5 centimeter and TRADS 4. Nodule more than 1 centimeter and TRADS 5. Nodule 4.2 centimeter and TRADS 3 in children. TRADS is the ultrasound staging of a thyroid nodule. So we all must be aware of the TRADS classification of ultrasound thyroid.
Dr. Abha, we can discuss the answers later. After you ask the questions at the end, we can.
Okay, sure, ma'am. Yes.
Yeah.
Madam, next question, ma'am.
So the answer is option A. Now question number 4, which is incorrect about Bethesda system for reporting thyroid cytopathology 2023? Option A, Bethesda category 1. It is a non-diagnostic and repeat FNAC. Now, option B is Bethesda category 2 is benign and requires follow-up. Bethesda category 3, it is suspicious for malignancy and molecular testing is not required. Option D, for Bethesda category 4, it is follicular neoplasm and need molecular testing.
And next question, ma'am.
So answer is option C. That is the category 3, suspicious for malignancy and molecular testing not required. Now select question number 5, which is true about the thyroid nodule. So you have to select that which is true. Option A, risk of malignancy is negligible in Bethesda category 3. Bethesda category 2 thyroid nodule do not require follow-up. Risk of malignancy is high if microcalcifications are present in thyroid ultrasonography. Option D is mixed solid cystic lesion has higher risk of malignancy than complete solid lesion.
Madam, next question, ma'am.
So the answer is option C. Number 6, which of the following statement is true about subclinical hypothyroidism? Option A, subclinical hypothyroidism is divided into 2 grades according to TSH cutoffs. Grade 1, that is TSH 4 to 10, and grade 2, that is TSH more than 10. Option B, All subclinical hypothyroidism cases require levothyroxine treatment. Now, option C, pericardial effusion is common in subclinical hypothyroidism. Option D is subclinical hypothyroidism cases progress to overt hypothyroidism cases in 50% of, it is 50% conversion per year. So you have to select the true statement in these options.
Ma'am, next question, ma'am.
So the answer is option A. Moving to the next question, question number 7. A 28-year-old female diagnosed to have Graves' disease since last 3 months is taking carbimazole 10 milligram 3 times daily since 10 and now has come to you for follow-up. Now she does not have any toxic symptoms. Thyroid examination is normal. Her thyroid profile suggests TSH of 0.003. FT4 is normal. FT3 is also in the normal range. So what is your next step? Increase carbimazole dose, option A. B, decrease carbimazole dose by 25 to 50%. Option C, continue the same dose. Option D, repeat thyroid profile from other lab.
Ma'am, next question, ma'am.
So the answer is option B. Now, question number 8. A 25-year-old female, primigravida, at 8 weeks of gestation, diagnosed case of primary hypothyroidism on levothyroxine 50 micrograms since last 1 year. Now comes with a TSH of 4.1, anti-TPO is positive, thyroid examination is normal. So what should be the next step? Option A, increase levothyroxine dose and target TSH level to less than 2.5. Continue the same dose and ask to repeat TSH after 4 weeks. Do free T4 levels and wait for the results. Do another TPO antibody levels and wait for the results. So the option. Very good.
Ma'am, next question, ma'am.
So it's a Sunday in the family. So intermittent disturbances. So now question number 8. The answer is option A. So the next question is question number 9. A 35-year-old male with anterior painful right-sided neck swelling and heat intolerance since last 2 weeks. History of fever, dry cough, sore throat 2 weeks ago. On examination, there is tachycardia, but no signs of heart failure, orbitopathy, or dermopathy. Now, thyroid examination suggests a right-sided 1:1, form to heart nodule present, mobile, severe tenderness is present over the thyroid gland, no lymph node palpable, and what should be the next step? You can see the thyroid profile on the right-hand side. The anti-TSH receptor antibody is negative. So option A is start antithyroid drug and a beta blocker. Option B, order ESR, CRP, USG NEC, start NSAIDs and beta blocker and plan for steroids. Option C is order FNAC of thyroid nodule. Option D is directly start steroids without further investigation.
Ma'am, next question, ma'am.
So the correct answer is order ESR, CRP, ultrasound neck, and start NSAIDs and beta blocker and plan for steroids. So the last question is 28-year-old female, primary gravida, 8 weeks gestation, but no thyrotoxic features. Thyroid examination is normal. General and systemic examination within normal limits now came with the following reports. TSH is 0.03, FT4 is 1.5 nanogram per DL, FT3 is 3.8 picogram per ml. Anti-TSH receptor antibody is 0.8, which is negative. Now, which of the following statement is true for this case? Option A, patient should be started on antithyroid drug. Option B, patient should be asked to just repeat thyroid profile after 4 weeks and stay in regular follow-up. Option C is patient should be started on beta blockers. And option D, low TSH levels in pregnant female is always pathological and needs treatment.
Madam, we're done with the quiz, madam. I can show the winners, madam, if needed. Ganvi, ma'am?
Yes. So the answer is option B. Patient should be asked to just repeat thyroid profile after 4 weeks and stay in regular follow-up. So thank you for your participation in this quiz.
Thank you, Dr. Abha, for conducting this excellent quiz. So I now request you to announce the quiz winners as well. So Sham can display the quiz winners. Dr. Abha.
Yes. So Dr. Lakshmi Priya, she is the winner of this quiz first. She scored 9 out of 10. Then Raj Kamal, Dr. Raj Kamal, he scored 7 out of 10. There is a tie between Raj Kamal and Dr. Nikhil. So Dr. Raj Kamal and Dr. Nikhil, they had 7 answers that were correct. And Dr. Shri Vaishnavi and Dr. HSK, they scored the third score, that is 6 out of 10. That is 6 answers were correct out of that. And I think the questions were quite easy and they were day-to-day, related to day-to-day practical cases that we usually get. So thank you, everyone. And I think the scores were very good. So yes, more than 50% they had scored above 5 scores.
It's like you rightly said, very clinically relevant questions. Thank you very much for the very nice quiz.
Thank you, ma'am.
Thank you, Mini ma'am, for moderating the quiz and Dr. Abha for conducting an excellent quiz. So congratulations to all the winners as well. So that brings us to the end of the session. So I now request Dr. Pramila ma'am, Dr. Mini ma'am and Dr. Arun sir to give their concluding remarks. So I extend my heartfelt thanks to all the speakers, moderators, panelists and attendees for their active participation and dedication as well.
So thanks, Dr. Ganvi, for excellently moderating the whole thing and carrying forward the sessions today. We got a bit late, but I think the discussions were good and we had a lot of insights on different topics on thyroid, starting from puberty to pregnancy to nodules and cognition. So I think it was a very extensive coverage of many on many topics on thyroid. And also the quiz was excellent. And as Dr. Abhamani told that at least some people scored about 50%. So that's good. That means we were a little bit successful in the spreading the knowledge about thyroid. So I also invite Dr. Mini and Dr. Arun to give their concluding remarks as well. And then we will close this session. So Dr. Mini and Dr. Arun, please.
I would like to thank all the panelists and speakers who have spared their time on a Sunday. And I would also like to thank Dr. Pramila and Dr. Ganvi and other core academic team who have been very successfully conducting these online meetings since January and even before that during the last year. Thank you very much.
Thank you, madam. And a special note of appreciation to the Indian Thyroid Society leadership, Dr. Krishna Sheshadri sir, who is the president, Dr. Sujay Ghosh sir, Dr. Pramila Kalra madam, who are the vice presidents, Dr. Arun sir, secretary, and Dr. Mini ma'am, who is the treasurer. So with that, if we'll take Pramila ma'am's permission, and with that, I think we can conclude the session.
Dr. Arun would like to say something as a closing remark. So,
I think
Dr.
sir
Arun,
is on
would
a
you
call,
like to-
madam. We can continue.
Okay.
Yeah.
Okay, fine. We'll continue with that. Yeah. And we definitely thanks our IT team as well, who have done an excellent job today.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Wish everyone a happy Sunday ahead. Thank you and goodbye. And we have our next scientific event on the 11th of June, which is our monthly thyroid clinics. We hope everyone can join us on our next scientific event. Thank you, everyone.
Thank you.